You have that this much room.
Hello.
We'll
Perfect.
put that at the back.
Okay, so this will be given. Good morning, everyone. Good morning. While we're waiting for the rest of the crew who is finishing rounds and so on and so forth to come in, I want to welcome you to the 18th Del Guercio de Luis Del Guercio Day, Research Day with a distinguished professor. But today's we combining two really important days. One of the graduation of our chief residents and initiation of our new crew of interns and new chiefs and new third years and new fourth years and new second years. And so it's a day of transition. It's a beautiful day. We have a really outstanding program, and I want to thank the research team and scientific team led by Dr. Diflo, Dr. Bergamaschi, and Dr. Smiley, and Castaldi, and everyone else for doing a magnificent job. I just want to tell you that I have nothing to do with the selection of the papers or articles because they were done actually. They did not know their names. They were anonymous. Kind of difficult to be entirely anonymous when we know who does what kind of research, but it's going to be an awesome day today. I will introduce our distinguished speaker today a little bit later on, but I just want to welcome Dr. Price, a great friend who came from Utah to spend a couple of days with us and educate us and inspire us, because I think what he does is amazing thing that you guys gonna really are for a treat. He's truly my hero, and I had been following his work for many, many years, even before we met. So thank you for being here, Ray, and I really appreciate you coming to spend some time in this corner of the world. As tradition goes, I'm going to ask Dr. Savino to speak about Dr. Del Guercio. Dr. Savino. You give you this too.
I got it.
Oh, you got it? Okay.
Let me turn this thing off. There it is. Well, good morning. We started all this not 18 years ago. Actually, we started in 2001. There was a brief period where we didn't have the Del Guercio lectureship and research conference. So it was a great experience to work with him for so many years. I came in 1981. And I think he started in 1976 as chairman till 2001. He was chairman for 25 years, which is most unusual. He was a great educator, clinician. He was a leader, and he was definitely, for many, many surgeons, a mentor. Let's see if this moves. Let's see. He didn't tell me what he wants me to use. Maybe this. No. Which one?
Let's just do that. There we go. You can use the arrows here.
Oh, good. That's better. Okay. So here you see him in the ICU, which is not unusual for him. Think about it. Back in his era and my educational period, there were no surgical ICUs. That was the prime thing that I think he did in his career. An outstanding individual. He eventually was a member of the founding committee for the Society of Critical Care Medicine. And he also was the fourth president of a society that was predominated by medical people, pulmonologists, et cetera. And he was one of the surgeons. It was Shoemaker from Mount Sinai. They would get on an airplane and go to the West Coast, because I think Shoemaker was at the West Coast. He had left Mount Sinai. In any case, now, anything you see that's artistic, take a look. If you look very closely here, he was a great artist. He was capable of doing this every single time he operated on. He would sketch the key component of the operation, hand it to the circulator and to the resident that participated with him in the case. It was a unique individual. And he eventually, even when he retired, he was painting. He's just an excellent artist. In any case, at that time, he had a competitor. It was two guys, Swan and Gantz. They were coming up with development of the balloon flotation using thermodilution. He was using the Fick principle with dye dilution. Unfortunately, when they compared the two, the Fick method wasn't, he would inject cyanine into the brachial vein, and then the radial artery, they would evaluate it with a densitometer, which I think is a subsequent, yeah, there's a densitometer. He was very oriented toward dye dilution. It wasn't as accurate of the flotation device, a balloon flotation device with the thermodilution. He recognized that the CVP was not enough, and that the pulmonary artery had to be introduced into medicine. See, we take it for granted, and now it's rarely used at our institution, where everything was, we had Swan-Ganz all the time if you were in the ICU. That's changed. Then he came up with an automated physiological profile. There it is. If you were on rounds with Del Guercio at 7 o'clock in the morning, there was no way that you would not know what that particular automated physiologic profile. And if you look carefully, there's a Frank, I'm trying to remember his name. In any case, that particular graph down in the lower portion, down here, you can see that this patient has a elevated wedge pressure, and the left ventricular stroke work was poor. This is a case where you gave fluid, you couldn't do it. You either had to use Lasix or you had to use an inotropic agent. So you imagine surgeons that are learning this from the first year. When he started, and Dr. Sarabone, I think, was in that year, 1981. He was tough. You had to be there at 7 o'clock in the morning because he wanted you to be there when he was there. And he was just an amazing human being, clinician, educator. And when I say clinician, he was a general surgeon and a thoracic surgeon. He operated on the neck, in the chest, and in the abdomen. He could do anything. There's only one thing he couldn't do. Couldn't use cautery. He never used cautery in his life. He refused to use it. So you can imagine that you had to tie knots. In any case, the automated physiologic profile really was a format of primary and derived parameters of myocardial function, oxygen function, and the function of the lungs, pulmonary function. And as I said before, he's one of the founders and president of the Society of Critical Care Medicine. He then had this idea. There were 4 beds on the 5th floor. And what he believed at that time, and the insurance companies actually paid for it for a while, He wanted to evaluate patients with a Swan-Ganz catheter inserted before they went to the operating room to find out what their myocardial reserve was. So if we challenge them with fluid, in fact, I put mask trousers on people. That's one way of giving fluid and then releasing it immediately. Stiles had done it first, and we published that. This unit was outstanding. He knew and published it. If you ever want to go back to it, JAMA in 1981, he published this. This is another area. This is his drawing. If you look carefully, it'll be in here somewhere. He puts his name usually on everything. You know, it's not on this one. But in any case, he believed that the modified Segura method was the way to go with patients with esophageal bleeding from portal hypertension. He was an expert with hypertension. He did so many shunts in his past. I think when he was at Einstein, he felt this was the best way to do it. The only problem is we had a lot of patients with ascites. In fact, I had a publication that I think you recently saw. That's because a lot of these patients, this is a devascularization where you're blocking this area, ligating the splenic artery, so there's less portal flow. The inflow was diminished. This is on the lesser curvature. And here he's on the anterior wall of the stomach. So what he's doing is cutting off the inflow of fluid. He knocked off the coronary vein as well by doing this maneuver. But that wasn't good enough, because this definitely wasn't Dr. Del Guercio, because you notice right here, there's cautery. This must have been one of us. He believed that he had a relationship with the VIR people. And he said, we've got to do something that's effective, that I don't have to do a major operation. And here you see the small bowel where there's a vein, a mesenteric vein that is in the mesentery. This advanced a catheter up into the superior mesenteric vein and into the portal vein. And what they would use is John Turco coils, which I'll show you on the next slide. The head is on the left. All right, you can see in this area, the coronary vein and a lot of varices here. These patients were all bleeding. Now, there was no GI people that could put a band on varices at that time. It didn't exist. The surgeons had to take care of GI bleeding from varices. You can see after putting a John Turco coil in the coronary vein, here it is blocked, and you can see, look at the John Turco, these are the coils with the assistance of the VAR people. That eliminated the flow into the varices. The only problem is the portal hypertension was increasing, and we had a lot of ascites afterwards. That was the one negative, well, of many things. Here he is drawing again. He said, well, we've got to come up with a different way. And in fact, what he did, he said, why don't you put in Dr. Rosenblit, who's still here, go into the femoral vein and get me up into the hepatic vein. Because when they first came out with the TIPS procedure, transjugular a shunt between the portal system and the vena cava. The problem with that is initially there were many publications that came out, and the VIR people could not know if they were in the liver or not. So again, Del Guercio said, well, there's a better way to do it. Why don't you get me up to the hepatic vein, going from the femoral vein up through the vena cava? So this is, you can see it, it's right in the hepatic vein, but you really can't see that. And by using the mini laparotomy, he was able to get a catheter up into the mesenteric vein and into the portal vein. So they knew exactly, they're right here, they're in the liver, they put the shunt in. So that's how TIP works, Del Guercio way. Then eventually the VAR people became very effective, and they did the transjugular, which was a much better way. But this was an experience. He was willing to do anything. that he thought in his mind with research, and he was right many times. I was just telling you, never wanted to walk in a room and look over his shoulder. And some of the residents of the past, that was a tough time for the resident. So the attendings would walk into the OR just to look over his shoulder. And if he couldn't say today exactly what he would say to the resident back in those days. Times have changed significantly. Well, he retired in 2001, and he was a great mentor for me and for many others. He had a style that was absolutely unique, and he would paint. He would continue to go out on yachting. He was playing tennis, etc. But by 2013, he was a cigar smoker, unfortunately, and he would go on rounds and have it before he'd go into the Unit D, which was the only surgical ICU. He'd put his cigar in the room where you put the chalk before you'd walk in the unit. He'd have a cigar stogie in his hand all the time, not lit, but he was a character of characters. You know, I see Tony Sanfilippo there. I saw that there was a pen. You published something with him, with the Fick principle, with the cyanine green. Am I right, Tony? Do you remember it? Oh, can anybody else hear me? You can hear me. Okay. Well, anyway, Tony, you were doing the cyanine green dye method, and you were the first author on that. So I think the way I remember him as a mentor, there was just a way that he had with his residents and with his attendings. He was a very kind man, unselfish, and he was just an outstanding individual. He only had 8 children and 17 grandchildren only. But he would get home to the kids, but he certainly loved to fish. Loved to fish.
Dr. Savino, thank you so much. That was awesome. Every time with Dr. Savino does this, I learn something new about Dr. Del Guercio. I was lucky enough to meet him only once when he signed my certificate of critical care. And he was smoking a cigar. I could not see him when I walked to his long, dark office from smoking, but he was an awesome man. And because of this was a Swan Gans land, every one of us, when I did my fellowship at Lincoln, had to have those, what Dr. Savino described, the Frank Starlin curve and everything else that needed to do from the physiology we had to have at the bedside. So thank you. And we all, he probably would be really pissed off if he knew that we don't use Swan Gans anymore right now. So we're not going to tell him, right? Let me introduce Dr. Bergamaschi, who will take us through the morning session. Dr. Bergamaschi is the chief of colorectal surgery here with us.
Thank you, Dr. Latifi. Good morning, everybody. So I have the pleasure to start introducing the first speaker. We have Inkyu Lee, who's going to present for Schiff, Okumura, Bowden, Wolf, Partula, Dang, Gas, Spiegvogel, Singh, Glickwick, Wolf, Valette, John, Nishida, Bifilon, Sogawa, solid organ transplantation using hepatitis C virus positive donor organs for hepatitis C virus negative recipients in Westchester Medical Center, and update data. Thank you.
All right. Hello. Good morning, everyone. My name is Singyu. I'm a second-year resident in the general surgery program. So today I'll be discussing a solid organ transplantation using hepatitis C virus positive donors into hepatitis C virus negative recipients. And this is our experience at the Westchester Medical Center institution. So nothing to disclose. So just briefly, about 3% of the world's population has Hep C, and in the US, about 1% has a chronic Hep C. And since early 2000s, the treatment for Hep C virus infection has drastically improved. Initially, first approved drug came out in 1991, about 6% cure rate. Now it's approaching 95+% with the new generation of medications. In addition, as we know, there's always been a shortage of organs. Every year, about 21,000 kidney transplants are done, 8,000 livers. However, there's about 90,000 people that actually need kidneys and about 10,000 that need liver. So there's this unmet needs. Hep C positive organs has been used for Hep C positive recipients for a while and is considered a standard practice. But however, because of the shortage of organs and in addition with the improvements in the antiviral treatments for Hep C, it's reasonable to consider Hep C positive donors into Hep C negative recipients. And there are recent trials that show that, for example, in two papers showing that in kidney transplant, they approached 100% sustained virological response after treatment for folks that received Hep C organ and seroconverted into Hep C positive status. So at WMC, we started using Hep C organ back in 2017, in July 2017, and here to discuss our results here. So the outcomes include graft patient and graft survival, infection, HCV infection rate, as well as infection-related complications. So this was a retrospective cohort study of all solid organ transplantation. They're either Hep C antibody positive, nucleic acid or NAT positive, or both. And this was, the study includes all the transplant that was done from July 2017 until December of 2020. And all patients who seroconverted to Hep C positive state received antiviral treatment for 12 weeks. So total 56 solid organ transplantation was done using Hep C positive organ into Hep C negative recipient. These are the numbers for each organs. So most of them, 64.2% were received Hep C antibody and NAT positive organs. About 27% received Hep C antibody negative but NAT positive organ, and about 9% received Hep C antibody negative but Hep C NAT positive organ. So for those who received the NAT antibody and NAT positive organ, essentially 100% converted into Hep C positive state. One patient was excluded due to patient dying of the prostate 1 from PE. For those who received the antibody positive NAT negative, 13.3% seroconverted. For those who received antibody negative but NAT positive, about 40% are converted to seropositive state. So as I said earlier, for those who had a detectable Hep C RNA post-op, they all received 12 weeks of antiviral treatment. One patient had a recurrence of a Hep C virus after the treatment, but was cured after a second course of treatment. There was no major adverse events due to the hepatitis C virus treatment. The total patient survival in our study was 89.3%. So 6 patients out of the 56 transplantations that were done died. 3 people were from the Hep C antibody positive, NAT positive group. 2 were from the antibody positive, NAT negative group, and 1 person was from antibody negative net positive group. So to conclude, transplants from Hep C positive donors into Hep C negative recipients appear safe, and also the antiviral treatment is effective. We were able to achieve a 100% Hep C cure rate. And although the significant portion of 100% of those that receive antibody positive, net positive, seroconverted, and 40% and 13.3% of the the either one or antibody or net positive seroconverted, those cure was 100%. And of note, those that received antibody positive but net negative, they had a significantly less chance of converting into seropositive state. And this is similar to the previous reported data back in 2018 that showed about 9% seroconversion rate. So even though the percentage is lower than those that receive a net positive, there's still a significant risk, and therefore these patients need to be closely monitored. References, and that's everything. Thank you for your attention. Here, thank you.
Speaker, we have Kenji Okimura. The co-authors are Deng, Sugawa, Butler, Ballet, John, Diflo, Bowden, Wolf, Latifi, and Nishida. The title of the talk is Inferior Early Liver Transplant Outcomes During COVID-19 Pandemic in the United States.
My name is Kenji, one of the PGY residents here. I'm going to present the liver transplant outcome during COVID-19 in United States. Nothing to disclose. As people know, the COVID-19 has been pandemic last year, and then WHO declared the COVID-19 pandemic March 11, 2020. COVID-19 had a significant impact on the routine healthcare. Early in the pandemic, there was no intervention for prevention, treatment, risk of spread of COVID-19, but all of them were not well defined. Especially the immunocompromised patient, including the solid organ transplant recipient, at the high risk for significant morbidity and mortality from COVID-19. So the aim of this study was to analyze the effect of COVID-19 pandemic on liver transplant in the United States. We retrospectively analyzed data from the UNOS database. We included all liver transplant recipients above the 18th between 19 to 2020. We defined the pre-COVID period is March 11 to September 11, 2019, and then COVID period is March 11, the same time, 2020. So we analyzed the patient characteristics, the outcome, number of transplant, graft survival, patient survival, hospitalization, the length of stay, rejection episode prior to discharge, death from the COVID infection rates. So here's the result of the each groups. The pre-COVID period, 4,277 patients had a liver transplant. In the COVID, 4,107 patients received the liver transplant, but about 4% decreased during that time. There is no different age, gender, race. However, the primary etiology in the alcohol liver disease has been significantly increased. Here's the wait list period. In the COVID, the wait list period has been significantly decreased. And then the patient requiring dialysis also increased. The MERD score, it's the how severe the liver disease is significantly increased in the COVID era. Here's a donor characteristic. There's no difference the age, female, age, gender, race, and there's no difference the living donation rate between the pre-COVID and COVID era. We look at the donor risk index. It's one of the indicator to demonstrate how the donor liver quality is, including the donor age, race, age, and cause of death. That the higher is higher risk. So, and then the indicator itself has been significantly higher in the COVID era. And then here's the result of the outcome. We divided the March, April, May, and then as you can see, in the first March, the number of the liver transplant has been significantly decreased. However, during the May, June, the number has been backed up. Probably this is going to be reflecting the people know how the COVID is and then starting to the program. And then also distance the miles. It's a new allocation system policy has been applied from the 2020. And then the distance from the donor hospital to recipient hospital has been significant increase in the COVID era. And then interestingly, the acute rejection episode before discharge has been significantly increased in the COVID era too. And then the length of stay has been the same. The patient survival and then graft survival was significantly decreased in the COVID era. Here is the number of liver transplant between the COVID and the pre-COVID era in each region. Each region has a significantly changing, but most of the region has been decreased the number of the liver transplant. Here is a Kaplan-Meier survival curve analysis for the patient survival and graft survival. As you can see, the pre-COVID era has been the better outcome compared to COVID, and then the survival curve has been significantly spread after 30 days from the transplant. And then we performed the Cox regression and multivariable analysis for the graft survival. Then COVID period has been significantly increased the risk. The hazard ratio is 1.77. The other factor has been the well-known factor for affecting the graft survival, the portal vein thrombosis and the retransplant called ischemic time. Here's the conclusion. So overall, 4% fewer liver transplant was done in the COVID period. Alcohol liver disease was the most common primary diagnosis during the COVID period. And then during the COVID period, the liver transplant recipient had a higher MELD, lower waiting this time, higher need of hemodialysis before transplant, higher rate of multi-organ transplant. Donor risk index was significantly higher in COVID period. And then graft survival and patient survival was significantly lower during the COVID period. And then the rejection episode before discharge was significantly higher. This has been reflecting the most of program trying to cut down the immunosuppression. COVID-19 was a primary cause of death, about 3% in the total deaths after transplant. And then multivariable Cox regression analysis showed the COVID-19 was one of the independent risk factor for graft failure. Thank you for attention. I'm happy to take questions.
for a great presentation. Any questions, please? Dr. Bismarck?
Comment. I'm not sure if you can hear me from this, but a couple of things. First of all, just to reflect on really the excellence here at Westchester Medical Center. The state of New York has been tracking COVID infections in post-transplant patients across the entire state in all post-transplant patients. Here at Westchester, we've had about the same percentage of infection in our patients, about the same incidence of hospitalization in our patients. But as far as, and ICU admissions are about the same as well, but as far as the really important things, intubation and death after COVID infection, Westchester had a rate approximately 50% of the rest of the state. I think this reflects a number of things, primarily the effectiveness and the help of our transplant infectious disease service run by Dr. Dond, and also obviously the outstanding critical care that's available here at Westchester. And I know Dr. Ree and his team was really instrumental in that. So just to say rah-rah Westchester a little bit, I want to point that out and how important that's been for our patients. Thanks.
The med score was higher during the COVID period.
I think a couple of reasons. So in the COVID period, if the patient doesn't need it, they try to avoid the liver transplant. And then the new allocation system has been initiated, and then sicker patient is easily to get the liver. That's another reason, I think.
Which is alcohol. COVID caused a great deal of despair amongst a lot of people. We saw a tremendous uptick in acute alcoholic hepatitis and exacerbation of alcoholic liver disease. And those patients came in, this is just our local experience, those patients came in extremely sick, many of them with MELD scores 40 plus, and many in renal failure. So I think the contribution of acute alcoholic disease was really significant, and that was seen really nationwide.
Thank you. Any other comments or questions? Thank you, Ken.
Thank you.
Okay, hi everyone. My name is Charisma Chabra. Today is the last day that I'm a third-year medical student, so going to be a fourth-year student. I will be presenting race-conscious learning in an academic surgery program, a diversity and all-inclusion program, and this is something that I worked on with members of the Department of Surgery. Thank you. I have nothing to disclose. So race-based associations in medicine are often taught and learned early on in medical education. There are implicit and explicit biases that are within the medical educational environment, and students and residents eventually go on to reinforce these biases unknowingly as they practice medicine. The consequence of this is that trainees will develop harmful stereotypes based on the belief that some populations are more diseased than others, or that race is associated with certain disease conditions. So in an attempt to address this issue, the Department of Surgery has committed to the creation of an all-inclusive and diverse learning environment with the following objectives: incorporating race-conscious awareness and learning, cooperatively learning about race in clinical and surgical decision-making, incorporating learning about the social determinants of health that lead to racial and ethnic inequities, and developing racially tailored learning in order to recognize and ultimately lessen health inequities. So these objectives were carried out in 3 phases. Phase 1 is initiation and organizational structure. The chairman of surgery appointed a vice chair for diversity and inclusion. A D&I committee was formed to include faculty, residents, medical students, and support staff. At the first meeting that we had, the goals of the committee were initially laid out by the committee chair. And then these goals and the activities of what the committee would do were further developed and modified by the committee members. So after the first meeting, our official committee mission statement was declared. And so our mission is to create a supportive and inclusive environment where all are valued and have the opportunity to achieve their highest potential, irrespective of ethnicity, gender, religion, race, or personal beliefs. We will champion diversity and inclusion for everyone, drive systemic, sustainable improvement in our workforce, and meet the educational and healthcare needs of our diverse community with cultural sensitivity. Then we come to phase 2, where we assess the current state of diversity and inclusion and race-conscious learning in the surgery clerkship and residency curriculum. A strengths, weaknesses, opportunities, and threats analysis was done. And so in strengths, we have a multicultural committee interested in making improvements. We have leadership support. In weaknesses, there's an overall poor awareness of these issues, as well as insufficient race-conscious learning in the curriculum. For opportunities to address this, we have the department's grand rounds. And in fact, we've had 2 grand rounds where diversity and inclusion were the subject of discussion. We also have the department's journal club. And the most recent journal club, we actually discussed a holistic approach to viewing general surgery residency applicants. And then when it comes to clinical decision-making, having a diverse healthcare team allows for race-conscious cooperative learning. Then when we come to threats, poor understanding and willingness to self-assess, recognize and implement change, and then a lack of awareness of clinical faculty across sites to race-conscious and anti-bias care. So now phase 3, the actual action plan. A baseline anonymous survey was created, and we actually did a trial run of this by sending this survey to committee members just to confirm the anonymity of the responses so that we could give confidence to the department once this survey was sent out, so that they're not concerned about any retaliation if they give their honest feedback. And so this baseline survey was divided into 2 parts. Part 1 just asks for demographic information, just so that we can assess the current makeup of all the employees in the Department of Surgery. And then part 2 asked if these employees felt supported and included in the department, as well as if they felt comfortable enough to speak up against discrimination. And the purpose of this was just to understand the current opinions on diversity and inclusion in the department, to assess the current representation, as well as gauge how the workforce corresponds to our patient population makeup. We also have the diversity and inclusion newsletter. This is something that we will have ongoing on a monthly basis or bi-monthly basis. And it's just to promote education and knowledge about other communities that are different from our own. And then we have the education and curriculum development focus, which is focused on the surgery clerkship for 3rd and 4th year medical students, as well as the residency curriculum. Just to talk about the education and curriculum development, there is a New York Medical College Racism and Bias Task Force that's been initiated. And the task force is commissioned with seeking out areas of racial bias present within medical education and developing solutions to eliminate them. We will do so by hopefully incorporating lectures into the curriculum, on implicit bias, bystander training, microaggression, cultural competency, responding to discrimination, and standards of respect. And then we would also like to incorporate scenarios where we can actually demonstrate any environments that may not be inclusive, and then how these environments can be turned around to be made inclusive. So for results, not only have we made the committee, but we've also have a committee that is dedicated to fulfilling all the objectives laid out by the Department of Surgery. We have publication of the bi-monthly D&I newsletter, which will be posted on the Department of Surgery website. And we have educational programs that are being created and reviewed by curriculum and program directors at NYMC and Westchester Med for the appropriate inclusion of race-conscious learning, such as image diversity, as well as race-based associations, awareness of social determinants of health in patient care, racial disparities in surgical outcomes, introduction of concepts on implicit bias with teachings on the same, opportunities for health equity rounds, inclusion in committees and leadership positions as role models. So just in conclusion, awareness of clinical faculty and learners for race-conscious and anti-bias care is paramount to recognizing and addressing biases. The knowledge of sociocultural contexts may allow learners to develop a socioculturally sensitive approach for patient education, selection, and informed consent, as well as allowing them to more broadly measure surgical outcomes. And then race-conscious education should be implemented into the teaching curriculum, as well as professional development in the attempt to close the gap in healthcare equity. And I just want to thank Dr. Latifi and the Del Garcio Committee for allowing us the opportunity to present this work.
Yeah, I don't have a question. You did an outstanding job.
Thank you.
And I really want to thank you for doing that, and thank you to the entire committee. And in particular, I want to thank Dr. You outlined every of what we need to do. So we have
Thank
a whole
you.
lot to do. And you are graduating with AES, so it's a year in transition. So
I'm
another
moving to
year.
fourth year.
You're gonna- you're not going anywhere.
Yeah.
And you're gonna keep working on this.
Mhm.
One day I want you to take Dr. right there position.
Oh, wow.
Great, thank you very much.
All patients who undergo a complex abdominal wall reconstruction at our institution We first started with a stratification analysis of 4 different subgroups: patients that had a history of a prior mesh and those who did not, the patients who had a BMI of less than 35 and those that had a BMI greater than or equal to, patients who had prior surgery for diverticulitis and those who did not, and patients who had a fistula takedown during their procedure with us and those who did not. We then developed 2 separate multivariable logistic regression models to look at both readmission and reoperation. Our primary endpoints being readmissions, both 30, 90, and 120 days, and unplanned reoperations following our procedure. Secondary endpoints being reasons for reoperation, timing until reoperation, the length of stay, and disposition postoperatively. So in total, we had 268 patients involved in this study with a mean age of around 59 years old and a mean BMI of around 32. 16.4% had a prior mesh placed prior to our procedure, and 17.2% required an unplanned reoperation. At 30 days, 10.8% had readmission. At 190 days, an additional 3% required readmission, and at 120 days, around another additional 3% required readmission. When we look at just the readmissions, the most common cause was a surgical site infection, around 50%, followed by seroma, wound necrosis, bowel obstruction, and some other causes such as pain, hematoma, and granuloma. When looking at reoperations, it was similar. The most common cause, again, was surgical site infection, followed by seroma and bowel obstruction. In terms of the timing of reoperation, around 2/3 occurred after their discharge from their index procedure, with the most common period being within 30 days and from 31 to 90 days, with a mean of 38 days after their abdominal wall reconstruction that required the reoperation. We then performed a generalized additive model, which is a way of looking at 2 variables, including a continuous variable, without assuming a linear relationship, that showed us that at a BMI greater than or equal to 35, it became significant in terms of both of readmissions and reoperations. So we then used this number and combined with the presence of the prior mesh to create a new variable looking at the interaction between the 2, rather than just each of them individually. This allowed us to analyze whether or not it was the BMI, the prior mesh, or the combination of the 2 that was driving these events. Here we see the readmission regression. And as you can see, for 30, 90, and 120 days, the combination of the prior mesh and the BMI greater than or equal to 35 was more significant than the 2 alone. We also see that prior surgery for diverticulitis and fistula takedown during their abdominal wall reconstruction both increased the odds of requiring readmission following our abdominal wall reconstruction. Here's just some examples of prior mesh that were removed during the procedure and a patient that unfortunately had a large fistula, both of which just to kind of show why exactly these would cause readmissions, reoperations, and infections. Here's another way of looking at our readmissions, first 90, then 120. And the reason we include this is you see here, you can see both the presence of mesh this direction and the BMI above 35 both increased. But when we look at this corner with both the BMI greater than or equal to 35 and the presence of prior mesh, it was significantly larger than all of the others. We see a similar picture here at 120 days. Then when looking at reoperation, it was a similar finding with both the combination of BMI and prior mesh being the most significant factor, with around an odds ratio of almost 8. As you can see, the presence of the prior mesh and the BMI alone weren't significant, but when the 2 were included in the same patient, it significantly increased the risk of reoperation. And again, we see prior surgery for diverticulitis and fistula takedown increasing their odds of requiring a reoperation. So in conclusion, we see that the majority of unplanned reoperations following an abdominal wall reconstruction occurred after their initial discharge, and were most likely due to infection, seroma, or small bowel resection. In addition, the presence of a prior mesh placed prior to our procedure, in combination with a BMI above 35, were significantly impacted the readmissions and reoperations following abdominal wall reconstruction, along with prior surgery for diverticulitis and fistula takedown. Any questions? I'm sorry, what was that? Yes, this patient actually has done very, very well post-operatively. He hasn't had any complications so far, and he's doing great. I actually have a picture later on in one of my talks later of the inside view of this, where you can see almost a mushroom cloud of bowel stuck to a prior mesh. He had pretty much every risk factor, but he's thankfully doing very well. Mostly enteric. A lot of them had both the fistula and a prior mesh, oftentimes of a mesh eroding into small bowel, but the majority were small bowel fistulas. This is all synthetic mesh. And we make a point during the, oh, I'm sorry, the prior mesh was synthetic. Our mesh that we placed was biologic. Yes. And we make a point during our procedure to remove all of the prior mesh because we've done studies in the past that show that leaving part of the mesh increases the complications postoperatively.
We will speak about early colostomy, reversal, mistakes, and cost-effective patient underlying diverticulitis, solvers,
Okay. Good morning, everyone. I'm Mohammed. I'm one of the third-year surgical resident. First of all, I would like to thank the program committee for giving us the opportunity to present our work. I have nothing to disclose. Acute diverticulitis represent a significant healthcare burden in the United States. It is estimated that annually approximately 400,000 admissions are related to acute diverticulitis. Most of these patients are managed conservatively. A small proportion of these patients usually require surgical intervention such as Hartmann's procedure. Once the patient undergoes Hartmann's procedure, usually the surgeons try to determine when to reverse them. There are several small institutional studies which have been performed that demonstrated the safety of reversal as earlier as 3 months. But there's no large studies so far. So the aim of our study was to evaluate the timing of colostomy reversal and outcomes from a larger national database. And we hypothesized that early reversal within 3 months after Hartmann's procedure is safe and cost effective. Moving on to the methods. For this, we performed a 5-year analysis of the national readmission database, and we included all adult patients who were diagnosed with acute diverticulitis during index admission and underwent Hartmann's procedure at that time.
and then followed, they were discharged, and then they came back for colostomy reversal within 6 months of discharge. We excluded patients who were readmitted during for other reasons other than the Hartmann's reversal after their index operation. We then stratified the patients into two groups based on when they got their colostomy reversal or Hartmann's reversal, into early, which were less than 120 days or 3 months, or late, which was more than 3 months. Our outcome measures were post-reversal complications and mortality to evaluate safety of early reversal, and we performed these analyses to evaluate these outcomes. Moving on to the results, this is a very busy slides. It just compares the two groups who patients who underwent early reversal versus those who underwent late reversals. As you can see, patients who underwent late reversal were more likely to be older. They were more likely to have comorbidities such as hypertension, CHF, and chronic pulmonary disease. Also, they were less likely to have a private insurance, and they had higher length of stay in the hospital as well. When we looked at the hospital charges, we found that patients who had late reversal were more likely to have higher hospital charges compared to those who had early reversal. We then performed a regression analysis to identify factors which contributes to the late reversal of Hartmann's. We found that patients who were more likely to be elder had lack of private insurance or comorbidities such as CHF, chronic pulmonary disease, or hypertension were more likely to get Hartmann's reversal later after 3 months. However, there was no difference for gender. We then performed regression analysis to see if late reversal or early reversal was associated with any complication, or if it's safe to perform early reversal. We found out the only difference was that late reversal was usually associated with higher rates of or higher odds of a urinary tract infection with odds ratios 1.32. However, we did not find any difference in the rates of ileus, post-op leaks, sepsis, or even post-op hemorrhage, which demonstrates that early reversal is safe as well. Certain limitations for our study. First of all, it's a retrospective studies. Always we start with retrospective studies and then move on forward with a prospective studies. We were also unable to ascertain if the surgical complexity of the index Hartmann's procedure, what was the initial Hinchey classification of diverticulitis, or other surgical variables that were associated with closure or Hartmann's reversal, such as operative time during Hartmann's reversal. Also, there may have been certain surgeon bias or hospital policies or institutional policies that may have determined when to reverse a colostomy. In light of our study, we conclude that late Hartmann's reversal was associated with longer hospital stay and increased hospital charges compared to early reversal. Independent predictors of late colostomy reversal were age, lack of private insurance, heart failure, chronic pulmonary disease, and hypertension. And then we conclude that colostomy reversal is safe as early as 45 to 1 or less than 3 months after the initial procedure. Thank you. I'll take any questions. So Dr. Bergamaschi is asking if we have any information, if we used any perfusion imaging during the operation to see, or if there were any impact of that on the anastomosis leakage. That's one of the limitations of our study, that we do not have any intra-op findings of these procedures to see if that would have been that would have impacted the post-op leak rate or not. But it's definitely useful, but we're doing a prospective study, and I think that would be a really good study to do to see if it predicts post-op leaks.
Any other comments or questions? Dr. Ashdam.
Oh, we excluded all those patients, so we did not I don't have a data with me right now, but definitely we can look into that.
All right, any other comments? Yes, Dr. Castaldi.
So
Dr. Castaldi is asking what is the issue with the insurance?
So previously, they said that getting clearance if patients have private insurance is based on the previous study. If patients have a private insurance, it's easier to get medical and surgical clearance compared to those who have Medicare or Medicaid. Yeah.
Any other questions, comments? Thank you, Mohammed.
Thank you.
Great talk. Our next speaker is Egon Kaimoli. He will present early abdominal wall reconstruction with biologic mesh is feasible after catastrophic abdominal wall disruption from blunt trauma. His co-authors are Azim, McGurk, Prabhakaran, Sampson, Ree, and Latifi.
Good morning, everyone. My name is Agon Kaimoli. I'm a research fellow. I'd like to thank, firstly, Dr. Latifi. I'd also like to thank the Del Guercio Committee for giving me the privilege to present my paper today. I'd also like to thank the guest professor, Dr. Price, which I had the pleasure of meeting yesterday. The title of my paper is Early Abdominal Wall Reconstruction with Biological Mesh After Catastrophic Disruption of Anterior Abdominal Wall from Blunt Trauma. Again, I'd like to thank my colleagues and continue. I have nothing to disclose. Traumatic abdominal wall hernia is after a blunt mechanism is actually very rare. And from the reports, it's about 0.7 to 1%. However, with the increased utilization and improvement of CT scans in trauma care, we're seeing more and more of these problems arise. They often result from high energy injuries in the adult population. They can also be seen with handlebar injuries in the pediatric population. The mechanism is blunt force resulting in high intra-abdominal pressure in combination with increased shearing forces over bony prominences. This is the table that is predominantly referred to when describing and grading these types of injuries. Essentially, it's a grade of 1 through 6. In particular, for our presentation, we had very sick patients, and our patients were hovering around 4 to 6. Now, this table is very informative, but I think it just doesn't do a good job to really demonstrate how severe these injuries are. If you look at this CT, I'll be quickly. Here you'll see all organs basically it's outside the abdominal peritoneal cavity. Bit of a lag. This is what you see externally. And then once they incise the superficial skin, you have all these intestines just popping out ready. Now, as I said, these the mechanism required to cause these injuries are usually very high, and therefore it's no surprise that you'll have a lot of concomitant injuries. Here we have demonstrated some of the injuries that occur often to the intestines and often to the surrounding structures, including soft tissue that's underlying called Morel-Laval lesions. Here we have orthopedics has helped with the bone injuries. And then we were able to, because the injuries were so low, we were able to plate some and attach the biological mesh for better, stronger reconstruction. I'm going to speed this up slightly. But there you see the mesh. And then the anterior fascia over top. And yeah. There is a gap in literature, however. There is no consensus in how to treat these initially. And there's two reasons for that. A, as I mentioned, the low incidence. And number two, a lot of the trauma surgeons are more concerned about the concomitant injuries that are often more life-threatening. We present here 7 cases of high energy induced abdominal wall hernias that were treated at our center with our specific technique in the acute phase. Our study design was a prospective single-arm study. Our span was 2017 to 2021. Our inclusion included adults over 18, patients who obviously had traumatic abdominal wall hernias on blunt trauma mechanism, and no prior abdominal wall hernias or reconstructions. Our total, the total database that we had for our prospective analysis was 268 patients. 7 met our inclusion criteria. Our primary endpoint was hernia recurrence and technical success. Our secondary endpoints was length of stay, length of ICU stay, associated intra and extra abdominal injuries, morbidity, and mortality. Our median age was 55 years old. The female population represented 43%. Our median ISS, it was severe, they're very sick, was 34. I'd like to emphasize that majority of it was motor vehicle crash. Here are some of the other culprits from literature. Seatbelt sign was seen in the majority of patients, and our patients majority of them were in grade 5 category. As mentioned earlier, these injuries often have associated injuries. We are looking at the intra-abdominal injuries here in this table, and what you could see is that the hollow viscous organs are at most risk, followed by some other mesenteric injuries. When we looked at extra-abdominal injuries, extremities and overall orthopedic injuries was the predominant force, the predominant injury, I apologize. This table just shows us that we operate in all these patients during their index admission of trauma. However, the time frame varied depending on the associated injuries, as well as the need for take-backs in the OR. So although predominantly our patients were operating in the first week, within the first week, we have patients with some within the first month, and even an outlier here that we did after the month. There are limitations to this. It is a single arm study, so generalizability is limited. Inherent to the study design, there's also a selection bias, as well as our power was low. However, we were able to at least show that these can be repaired safely with biological mesh, even in the presence of hollow viscous injuries during the same index hospitalization. Thank you. I'll take any questions now.
Thank you. Comments? So the next speaker will be a virtual presentation given by Radu Filipescu, who is a New York Medical College graduate. The title will be Field and ED Physiology Trends Improve Performance of Modified Revised Trauma Score. And Filipescu has a number of co-authors. That's Powers, Tian, Yu, Bass, Harmon, Clemency, Guo, and Palesti, and Rothstein.
Good morning, everybody. My name is Radu Filipescu. I'm a preliminary PGY1 with St. Mary's Hospital in Waterbury, Connecticut. And I'll be presenting field and ED physiologic trends, improved performance of modified revised trauma score. Field trauma triage criteria are the current guideline in the decision making whether to transport to trauma center or not. It has 4 categories of criteria: physiologic, pattern of injury, mechanism of injury, and pre-existing conditions. TQIP introduced the first 3 categories in the 2017 dataset. Physiologic criteria are represented by the very variables used to calculate revised trauma score. Last year, we validated an improved version of RTS modified revised trauma score using age-adjusted shock index and oxygen saturation instead of systolic blood pressure and respiratory rate, and added temperature. For clarity, TQIP records the aforementioned field trauma triage criteria, vital signs in the field and ED, and other significant field events like pre-hospital cardiac arrest, requirement of supplemental oxygen, and respiratory assistance. We hypothesized that by adding the difference delta between ED and field vital signs and the field trauma triage criteria would potentially increase the accuracy of MRTS. From over 1 million patients included in TQIP, after eliminating incomplete data sets, we included almost 400,000 patients. Variables included were the field and ED values of Glasgow Coma Scale, systolic blood pressure, respiratory rate, shock index, oxygen saturation, temperature, level 2 and 3 field trauma triage criteria, and the difference delta between ED and field vital signs. Shock index was used as a Z-score. It was age-adjusted, and the reference category was represented by patients with ISS less than 10 who were discharged to home in the same day. Temperature was only present in the ED vital signs. Analysis included a stepwise logistic regression to determine variables predictive of outcome, survivor, non-survivor, and area under the curve comparison. The delta values were compared using t-test, Mann-Whitney U-test for distribution, and Kruskal-Wallis for median. All MRTS components were strongly significant. Delta shock index was not significant, and the most plausible explanation is that delta was not large enough to have an impact. Patients with high shock index in the field had high shock index in the ED and vice versa. Delta oxygen saturation and delta GCS were both significant. Larger the delta, greater the mortality. Pre-hospital cardiac arrest and supplemental oxygen requirement during transport correlated with increased mortality. Early ventilator support, however, was protective. From the field trauma triage criteria, skull fractures and paralysis correlated with increased mortality, while crushed limb turned out to be protective. Here is an analysis of the delta. The main characteristics we looked at were whatever was positive or negative, and compare the median and the distribution between survivors and non-survivors. Delta shock index was not large enough to impact the regression result. However, non-survivors had higher median values. The values in non-survivors either remained high or increased during transport. Delta SpO2 also had higher median values in non-survivors. Non-survivors characteristically had low SpO2 values in the field, which improved with intervention. Survivors who required oxygen in the field had more discrete improvement. We noticed a high dispersion in delta GCS in survivors. As both medians are 0, we can infer non-survivors had a low GCS in the field, which did not improve or worsened during transport. Overall performance is lower when using field vital signs. The addition of delta to MRTS increased the model's performance. The addition of field trauma triage criteria did not increase accuracy in any of the studied models. In conclusion, lack of improvement in neurologic status, persistent hemodynamic instability, and supplemental oxygen requirement during transport are strong mortality predictors. Delta GCS, delta SpO2, and very likely delta shock index, given a larger sample, increase the MRTS accuracy. Field trauma triage criteria are good in deciding to transport to trauma center. However, they're not good outcome predictors. And trend rather than single measurement appears to be a better predictor in trauma outcome. Thank you so much, and I'm looking forward to your questions.
We have any communication with the speaker at this time? Right, so we'll move on to the next speaker. Let me introduce Bardia Zangbar, who will speak about trauma registry-based initiative to improve documentation and quality of DVT prophylaxis using data from the Trauma Quality Improvement Program. The co-authors are Zangbar, Fisher, McGuire, Ree, Prabhakaran.
Hello, everyone. I would like to thank the program committee for a privilege of the podium presentation. And I would like to thank my colleagues for helping with the presentation and Dr. Prabhakaran, the senior author. I have nothing to disclose. Trauma patients are at high risk for developing the DVT and prophylaxis. DVT prophylaxis is standard of care in trauma centers. Incidence of the DVT is usually captured by the program registers, trauma program registers. However, the DVT prophylaxis is usually more challenging to capture in the trauma registry, and it's not the required field there. The aim of this study was to examine the effect of a registrar-initiated program to improve the real-time capture of the DVT prophylaxis on both documentation and the quality of the care. So we started with trauma program lead registrar, developed a custom field in the trauma registry as an internal audit to capture the DVT prophylaxis used for the patients. And we included all the patients with the trauma diagnosis and stratified by the type of the DVT prophylaxis. I color coded here, it's yellow and green. In the next slide, you'll see the fields. These registry was reviewed by PI coordinator and trauma medical director on a daily basis. And the errors were, findings were returned to the original abstractor for correction and capture of the correct information. As you can see, this is the trauma registry, and this is the field that used for the DVT prophylaxis, and this is the type of the DVT prophylaxis used for the patient. So a registry report was created to capture the DVT prophylaxis in a real time for admitted trauma patients, and the real-time communication was done between the trauma program manager and the clinical providers regarding a patient that have missed opportunity for DVT prophylaxis. This is an example of a DVT prophylaxis daily report. This patient is a sample patient 2020, has been ordered for sequential compression device only. And this was captured by the trauma registrar, and the feedback was done, communicated the problem to the medical team, and the patient's DVT prophylaxis was ordered appropriately in the patient's chart. So the results of the study, the initial capture rate for the prophylaxis, pre-implementation, we calculated the error rate was 40%. Post-implementation of this improvement, the calculated error rate decreased to less than 10% and sustained since. The daily registry-based capture of the DVT prophylaxis led to a real-time communication and opened the channel with the providers that can correct the errors and missed orders on a real-time basis. There was a decrease in the DVT and the PE in the hospital, in the admitted patients. The pre-implementation DVT rate was 1.3%, and pulmonary emboli was 0.45%. And post-implementation, the DVT rates decreased to 0.35%, and pulmonary emboli to 0.25. And this has been sustained since. This graph shows the difference between the 2019 and 2020. On the left side, you see the pulmonary emboli rate, and this blue column is the TQIP benchmark. On the right side, you see the DVT rate, which is dropped to 0.35 and is below the benchmark, TQIP benchmark. So in conclusion, the concurrent review and the correction of the trauma registry data improved the registrar efficiency by reducing the need for downstream corrective action of the both registrars and the clinicians. And a trauma registry-based performance improvement initiative based on the TQIP data has led to improvement in both documentation and quality of the DVT prophylaxis. Regular real-time audit of the both trauma registry and provider practice has been potential to improve the registry accuracy and performance, as well as the patient care related to outcomes in a sustained fashion. Thank you.
Well, thank you very much. We'll move on to the next speaker. That's again Matthew McGurk. Matt will speak about robotic inguinal hernia repair in an academic community hospital, analysis of 416 consecutive cases in 292 patients. The co-authors are Dr. Abuizi, Zoha, Smiley, and Dr. Atili.
Hello again, everyone. I'd like to again thank the committee for allowing me to present, and I'd like to thank Dr. Abuizi for helping me out with this project and allowing me to use his office up in Mid-Hudson for a week when we were going through the data. So the robotic repair of inguinal hernias is a surgery that's been increasing in popularity over the last few years, almost to a point where it has begun to replace the laparoscopic approach for fixing inguinal hernias. It's been shown in literature before to have minimal complications, be both safe and effective. However, most of the literature out there is on very few, very large center type studies. There's also very little data on robotic femoral hernia repair. Our study is an IRB approved retrospective cohort study spanning from October 2015 to March of 2021, with the eligibility criteria being all patients that undergo a robotic inguinal hernia repair at a single institution, Mid-Hudson Regional up in Poughkeepsie. The endpoints we looked at were concurrent femoral hernia percentage at the time of surgery, bilateral hernia percentage, operating time, length of stay, and then postoperative results, namely focusing on seromas and hernia recurrence among those. We started with a descriptive statistics of the entire cohort, such as age, BMI, their length of stay. Then we looked at the frequency of postoperative events, as I described before, and created a logistic regression model looking at the risks for all complications pulled together. To do this, we also created a GAM model to assess the linearity between age and the complications postoperatively, with it finding that an age above 55 years old is where it started to show significance. So this is the number we used in our model. Our aim was to show both the feasibility and safety of performing robotic inguinal hernia repairs at an academic community hospital rather than just a large quaternary care center such as Westchester, both having short length of stays, minimal complications, and infrequent early recurrence. We also aim to show that unexpected frequency of both femoral hernias in men and women, or women and men, due to the fact that there's not very much out there on femoral hernias in men. Most of the time we hear about femoral hernias, it's in female patients. So here we see the majority of our patients were male, with a pretty normal distribution. The most common of comorbidities, most common being hypertension, obesity, alcohol use, smoking. In terms of the hernias that we found and repaired, almost 50%, 42% were bilateral. And of those that were bilateral, only 68.5 were expected preoperatively. The other ones we discovered during the procedure. In terms of femoral hernias, 20% of patients ended up having a femoral hernia. And of those 60 femoral hernias found, only 10% were expected preoperatively, whereas the preoperative diagnosis was femoral hernia rather than inguinal or just groin hernia. In men, we found 18.4% of those that underwent the procedure had a concomitant femoral hernia, and none of which were expected preoperatively. In terms of postoperatively, almost 90% of patients were able to go home the same day. For those that were admitted, they stayed around a day. So in terms of postoperative results, the most common complication we found was seroma. As I said, there's 292 patients, of which combining the bilaterals gave us 416 total hernia repairs. There were 13% seroma was our highest rate of postoperative complications. In terms of those patients, only one patient, one of the hematomas required an intervention. It was just a drainage in clinic. In terms of recurrence, we only have one so far on short-term follow-up. We then also looked at the learning curve. There was 2 surgeons that were doing these procedures. And in terms of postoperative outcomes and operative time, there was no significant difference for the first 25 cases and those following. When we look at the regression model for predicting complications, age above 55 years was found to be almost 2.5 times more likely to have a postoperative complication. Here we see diabetes is close, p-value 0.06. Possibly with more patients, this would be significant as well. So in conclusion, robotic inguinal hernia repair can be safely performed at a community hospital with very few complications and very low early recurrence rates. The robotic repair also allows for detection of a significant amount of both unsuspected contralateral and femoral hernias, both of which can be repaired at the same time. There was no major differences of postoperative complications or operating time before or after the learning curve of 25 cases. And an age above 55 years old was found to be an independent risk factor for postoperative complications. Dr. Saldi?
Speak up.
Will the patients be consented going forward based on the findings for bilateral?
So in terms of like the operative consent, yeah, for the procedure, it's kind of shifted, whereas I know for the surgeons that are up there, most of the time now they do consent for possible bilateral repair rather than right inguinal hernia repair. Now it's right inguinal hernia repair, possible bilateral, due to the fact that we've seen so many bilateral hernias.
Dr. Tib.
If someone told me 5-6 years ago that you should do inguinal hernia replacement, I would have said you lost your mind. How many times we are able to even feel the femoral canal and look for unless it's really a decent valve that's stuck.
Yeah.
So I really like this procedure. Fortunately, I'm not as good a doctor of music because he's like superstar, and he does it so it makes it look so easy. As I try to do it, takes an hour and a half. But I really believe it's worth it. Compare this versus microscopic. There must be a comparison done, no?
Matt?
There wasn't much I saw. Dr. Abuzi?
Matt, I'm sorry. Matt, you may have said that I didn't catch it. Did you use, are you referring to a pre-peritoneal approach, or are you doing transabdominal?
Transabdominal,
There is no data on pre-peritoneal.
not with our procedures. for
Your
transabdominal.
series is purely to transabdominal.
Yeah.
Thank you. Any other point, please, sir? Thank you. Thank you, Matt. So the next speaker, I'd like to introduce Sharika Kaul, who is currently a sophomore at Tufts University. She will present Cancer Institute, A Place of Anxiety. The co-authors are Cotiel, Orlando, Parsikia, Rakucha, and Castaldi.
Okay, great, thank you. Hi, I'm Sharika Kaul, and I'm an undergrad student at Tufts University. I worked on this project during my summers, and I wanted to thank Dr. Castaldi for giving me the opportunity to work on this project, as well as the Del Guercio Committee for giving me the opportunity to present today. Nothing to disclose. Breast imaging can be associated with substantial anxiety in women, when the root causes of this can be either the perceptions of the risks of breast cancer, the impact of abnormal mammographies on stress, or a lack of knowledge regarding the implications of abnormal breast imaging. So many women believe that coming in after abnormal breast imaging automatically means that they have cancer. This anxiety can then progress into a fear that plays a major role in access to screening and breast health management. So women who experienced fear as a barrier to breast screening have delayed workup when screening exam is abnormal. A study at Westchester Medical Center in 2018 to 2019 of women who were notified that they had an abnormal mammography and had to come in for a diagnostic screening showed that 25% of patients did not complete their diagnostic mammography and 21% of women did not show up out of fear alone. Since these are significant numbers, we wanted to figure out why so many women had so much anxiety and what we could do to help diminish this to have more women come in. The main objectives of this study were to, 1, determine the level of anxiety in women after notification of an abnormal mammogram and if fear was a barrier. 2, determine if additional distress was provoked by their visit to the Cancer Institute. And 3, intervene to lessen anxiety in women during breast surgery consultations. This was a quality improvement initiative designed to focus on problem resolution, outcome improvement, and assurance of patient safety. An in-depth analysis of the numbers show rates of breast biopsy after an abnormal mammogram is 21%. The design of the study. So women presenting for BI-RADS for breast imaging were interviewed. These interviews assessed a number of factors such as patient demographics, subjective overall breast health, subjective anxiety levels, cancer history, and support system availability. This is an example of the interview. So the first half of the questions generally focused on patient characteristics, and the second half focused on women's specific reaction to coming into the cancer center that day. So a lot of women associated being in the cancer center with automatically having cancer. Patients were assessed in 2 groups, one being the baseline group that did not undergo the intervention, and the second being the post-intervention group. So women who underwent the intervention and were interviewed afterwards. These interviews were conducted with the questionnaire you just saw and asked them about their levels of anxiety, experience in the cancer center, and tolerability. This questionnaire was also translated into Spanish and conducted by a Spanish fluent examiner. These answers were categorized, and each category was analyzed using the chi-square testing. Significance was set at 0.05. About the intervention tool. So the intervention tool had 3 main parts: the patient navigation intervention, the educational materials, and advising patients to bring a companion to the cancer center. So the patient navigation intervention was a layperson who advised the patients and She had knowledge of breast cancer and was actually a breast cancer survivor. So she made patients feel a lot more comfortable and walked them through the process of coming in for an abnormal mammogram. The educational materials provided patients information about overall breast health and risk assessment, really clarifying to them that coming in after an abnormal mammogram did not mean that they automatically had cancer. And advising patients to bring a companion with them to the cancer center made them feel a lot more comfortable and less isolated through the process. Methods. So the levels of anxiety in the baseline group and the post-intervention group were compared using the chi-square test. Results. So 47 women were interviewed in total, 27 being part of the baseline group and 20 being part of the post-intervention group. 21 out of 47 women had increased anxiety entering the Cancer Institute, but the post-intervention women were significantly less anxious than the baseline group when they entered the Cancer Institute. So the words Cancer Institute triggered a lot less anxiety in these women. This graph also shows how bringing a companion was effective in reducing anxiety in women coming in after their abnormal mammogram. So the women who came in without a companion overwhelmingly felt much more anxious in getting their consultation in the cancer center, whereas the women who came in with a companion were a lot more comfortable in the cancer center and felt fine that it was okay to have this consultation done here or other places. In conclusion, a consultation with a breast surgeon in the cancer center provokes increased distress and anxiety for a patient. Educational materials and bringing a companion to the cancer center were proved to be effective tools in reducing anxiety in these women. Thank you all so much for listening.
Great talk. Any comments, please? Questions? Yes, Dr. Rashideo.
So they were basically with the patient through their visit. So they came in and kind of explained the process to them at the beginning of what it was like to go with them. And it was also able to kind of relate with them on a personal level because they had had breast cancer. And there was also then someone who was helping them while they were having their survey done. So the patient navigator kind of just walked them through an appointment and was there as like a support person for them.
Can I ask, is this a pilot study and you're planning to continue or?
Yeah, we hope these interventions will be put in place.
Dr. Babu, please.
Yeah, definitely. And since they also need to come to the cancer center, I think educating on them on what it means to come in is very important. But also if we were able to have them come in, not to the cancer center, I think that would make a significant difference in lowering their anxiety.
Any plans on that? Sir. Please.
Access to healthcare, I work on it around the world. Access to healthcare here in the United States as well. It's not based on just physical ability, but it's the anxiety and thoughts about what it means to go into breast cancer or colon cancer or something. Has a major impact. My wife, after going to get her mammogram, said once they make a machine that will squeeze my prostate as part of the mammogram squeezes her breast, and she'll do it. So I think it's a real issue, and it causes us to think about what are the next steps to see how we can. I mean, it's also an education to the public. What are other ways that we can try to alleviate that anxiety even before people come? You have thoughts of how you can use this to improve that ability. But 21% or so you mentioned.
Yeah, I think communicating beforehand is really important. Like I remember Dr. Castaldi was telling me that out of some of these patients who didn't come, they had called them afterwards, asking them why they didn't come in. And some people directly said that when I heard I had to go into a cancer institute, I automatically assumed I had cancer, and out of fear, I didn't come to my appointment. So just communicating to patients beforehand what exactly it means to come in after an abnormal breast screening, so they know what is going to happen. I think that would really improve the amount of patients who are coming in and also just reduce their anxiety in coming in for their appointment.
Shouldn't we have those names to begin with? Why would you call it something else? Why should we call it colon cancer institute? Call it colon institute. Avoid that name altogether. Yeah, you're welcome. Because frankly, I don't want to go to be checked as cancer myself.
Yeah.
And my wife too. We until kids died, we're going to mammogram. She did eventually. So 5 years later, this has been 10 years ago.
It's like having a colonoscopy at the cancer center. Yeah, yes, sir.
Travel further distances to get to a cancer institute. There's a switch. We have the cancer center in Manhattan. In this case, you know, it just wasn't that problem.
Sharika, thank you very much for your presentation.
Thank you.
Yeah. The next speaker is Egon K. Molly again. He will present timing for the treatment of traumatic thoracic aorta. Is there a rush? His co-authors are McGurk, Prabhakaran, Goldberg, Ree, Latifi, Babu, Kwon, Matteo, and Laskowski.
Yeah, the first one. Mhm. Okay. Hi again, everyone. My name is again Egon Karimoli. I'm a research fellow. I promise this lecture is not about hernias this time. I'd like to thank my colleagues, Dr. Latifi, and the Guercio committee for allowing me to present my paper. The title is called Timing the Treatment of Traumatic Thoracic Aortic Injury. Is there a rush? Nothing to disclose. Blunt thoracic aortic injury accounts for over 8,000 deaths per year in the United States. It's part of the first peak of death injuries. However, the majority of patients that do survive and are transported to the hospital, they actually survive traumatic thoracic aortic injuries. They are often the result from high intra-abdominal pressures and shear forces in rapid decelerating injuries, leading to aortic injuries at fixed, in areas where the aorta is fixed. Traditionally, these were operated on emergently and open. the endovascular aortic repair has largely replaced it as a standard of care. Here's just a visualization of the injuries. Grade 1, these can often be just watched with tight blood pressure control. Traditionally, grade 2 were operated on. More and more literature, sorry, I should take this off. More and more literature is showing that you can actually wait and watch for these as well. However, 3 and definitely 4 is operation. There's a gap in literature, however. Like I said, historically, these injuries were the ticking time bomb. So surgeons were told that these have to go to the OR, as soon as possible and done openly. Because they have a lot of concomitant injuries from the rapid deceleration injuries, these have been more and more delayed to try to repair other life-threatening injuries. And what we see in literature is that these can also be watched longer than we anticipated. So is it really the ticking time bomb we initially thought it was? Specifically also, there was no good indication for grade 3 blunt traumatic aortic injury, which if you recall was a pseudoaneurysm. Our aim was to demonstrate that patients with grade 3 injury can be endovascularly repaired in a delayed fashion, which we defined as over 48 hours, if hemodynamically stabilized and if the patients had other life-threatening injuries that precluded immediate repair. It was a single-arm study, age over 18, blunt traumatic aortic injury during the index admission, and they qualified for the endovascular repair. Primary endpoint was in-hospital mortality, secondary and open conversion. Secondary endpoints were as stated. The patients were seen both in an early and midterm period. We used the data set from 2007 to 2018, which was collected by the vascular team. What you can see from this table is that the median age was actually relatively young, 34. The majority were male, over 69%. Motor vehicle collision was the predominant injury mechanism, over 75. If you notice here, the isthmus was the most common location, which is like what the literature states. Also, the grade of injury was grade 3. So majority of our patients, 30 out of our 32 were grade 3, 94%. The median size is another thing that we had in this paper. Very few papers actually document the size of the pseudoaneurysm. The median was 2, which is 0.1 centimeters, which is relatively large. We wanted to also show the associated injuries involved. So what we analyzed here is that intrathoracic injury, unsurprisingly, is the most common, but these include sternal fractures and rib fractures. And then orthopedics comes second. In terms of procedures, thoracic procedures are the most common, but these included chest tubes and pigtails, which drove it up slightly. But other than that, other procedures and orthopedic procedures predominate. We also wanted to look at time to operation, and our goal was over 48 hours. Here we see that 2 patients were operated on immediately because one was a grade 4 and the other one had no other significant concomitant injuries. And the rest, the majority of patients were actually operated on within the first week. We had patients in the over 30 days as well during the same index admission, and they did just fine. Median length of stay was 34. And what I really want to focus on this is that there was no in-hospital mortality related to the TVAR procedure. 2 patients died, unfortunately, from their significant other injuries, including a catastrophic TBI and sepsis. So our data may suggest that it's safe to wait on these endovascular repair in patients with traumatic aortic pseudoaneurysms, which is the grade 3. Thank you.
Thank you very much. The next speaker is Douglas Evan James. He will present current trends, incident and management of blunt cardiac injury, an 8-year retrospective review with Shaneman, Bronstein, Gogner, Lombardo, Cohn, Prabhakaran, Ree, and Latifi as co-authors.
Good morning, everyone. I'm Douglas James, one of the Surgical Critical Care Fellows. Just want to thank the program committee for allowing me the opportunity to present, and Dr. Schneidman for all his guidance on this study. So the title of our presentation is Current Trends, Incidents, and Management of Blunt Cardiac Injury, an 8-year retrospective review. So blunt cardiac injury is a very rare traumatic injury. A lot of the difficulty in the literature is that there's not the standardized diagnostic criteria for the injury, making the diagnosis and understanding the incidence challenging. Reported in the literature, an incidence ranges from 8 to 76% of blunt trauma. And the most common mechanisms of injury reported in the literature is motor vehicle collisions, pedestrian struck, motorcycle collisions, and fall from height. The Eastern Association for the Surgery of Trauma published guidelines for screening for blunt cardiac injury in 2012. And they determined that EKG alone is not sufficient to rule out a blunt cardiac injury, but that EKG combined with troponin has an almost negative, 100% negative predictive value and is effective at ruling out blunt cardiac injury. Abnormal EKG and abnormal troponins, patients should be monitored. And they recommend echocardiogram in patients who are hypotensive, who have arrhythmias. But the outcomes of these patients, being such a rare disease, is not so well known. The AAST has a grading system, grades 1 through 6, for characterizing these blunt cardiac injuries. So our goal was to perform a retrospective analysis of the incidence and management of blunt cardiac injury at our suburban level 1 trauma center. So we performed a retrospective cohort review of our trauma registry from 2012 to 2020. We included patients with an age greater than 18 who had blunt trauma and a diagnosis of blunt cardiac injury. We excluded patients who had resuscitative thoracotomies or early mortality in the emergency department. 39 patients were identified. 26 patients were included after screening. And over this time period, for all blunt traumas, we had over 15,000 blunt traumas in the 8-year period, and 26 blunt cardiac injuries, giving our incidence 0.17%, which is less than on the lower end of what's reported in the literature, making this an extremely rare disease. In our study, the majority were from motor vehicle collisions, 76%, as well as pedestrian struck and bicycle collisions, similar to reported in the literature. The injury severity score was 21.5 on average, with a hospital length of stay averaging 20 days, ICU length of stay of 10 days, and 7.6 ventilator days. But there was wide variability in all outcomes. 61% of patients with diagnosis of blunt cardiac injury had abnormal EKG, but 70% of those were sinus tachycardia, and less commonly sinus bradycardia or atrial arrhythmias. Ventricular arrhythmias were very rare. We averaged the cardiac enzymes and CKMB, and those were mildly elevated to 1.6 and 26. The majority of patients got echocardiograms. However, only 15% were abnormal. All those abnormalities were typically a reduced ejection fraction, with some hypokinesis, but all the abnormal echoes normalized within 2 weeks. Associated injuries, we commonly think of sternal fracture as one of the more common, but pneumothorax and hemothorax were more commonly associated with blunt cardiac injury than sternal fracture. Surprisingly, of all the patients who were diagnosed over this 8-year period with blunt cardiac injury, none received antiarrhythmics, none received cardiac catheterizations, and none had cardiac surgery. So in conclusion, blunt cardiac injury is extremely rare. In our group, no interventions were required. Typically, these mild cases of blunt cardiac injury require no intervention, but I think this is such a rare disease, and it's important to remain having a high index of suspicion because injuries to the papillary muscles, the valves, coronary artery dissections, and all could be devastating. So you need to maintain a high index suspicion, though the majority of cases require no intervention. Thank you.
Please, any comments from the floor? Thank you very much. We will move on to the next presentation by Vardija Zangbar, who will present on mitigation of ventilation-associated pneumonia. And his co-authors are again Dalipi, Fisher, McGuire, Ree, and Prabhakaran.
Hello again, I'm Bardia Zangbar. I would like to thank the committee for privilege of the podium presentation, and I would like to thank my co-authors on this paper. Title is Mitigation of the Ventilator-Associated Pneumonia at a Level 1 Trauma Center, TQIP Data-Driven Multidisciplinary Approach to Performance Improvement. I have nothing to disclose. Ventilator-associated pneumonia is one of the most frequent ICU infections with a rate between 5 to 40% variable. This is because of the difference of the definitions in the multiple studies. Causes prolonged mechanical ventilation, prolonged ICU stay, increased costs, antibiotics burden, and its attributed mortality is about 10%, with higher mortality rates seen in the patients in the surgical ICUs and patients with the mid-range severity score at the admission. We looked at our 2018 TQIP benchmark report, and we saw a significant increase in rate of ventilator-associated pneumonia at our trauma patients, which initiated a comprehensive review of the TQIP data and trends. We set out to form a multidisciplinary technical advisory committee with the goal of reducing the ventilator-associated pneumonia. The aim was to assess the effect of the TQIP data-driven approach and formation of a multidisciplinary technical advisory committee on reducing the ventilator-associated pneumonia. A multidisciplinary committee was formed consisting of trauma medical director, trauma program manager, performance improvement coordinator, physicians, including residents and attendings, nurses, advanced practice providers, respiratory therapists, and trauma registrars. We created an evidence-based ventilator-associated pneumonia bundle with the following components: early mobilization of the ventilated patient, regularly scheduled oral hygiene, early initiation of the internal nutrition, and elimination of the benzodiazepine-based sedation, and early tracheostomy in the patients with severe TBIs. We reduced the average days for tracheostomy from 14 days to 9.1 days on average. Daily quantification of the ventilator days, head-to-bed elevation, 24-hour ventilator weaning and extubation as opposed to only daytime extubation, and algorithm-driven weaning and extubation of the patients. The bundle was used to educate the staff and trainees and incorporated into daily ICU rounds. Compliance with the bundle as well as a new ventilator-associated pneumonia were reviewed on a daily basis, and education on the loop closure were provided in the real time. Over the course of 3 years, we saw a drastic and sustained reduction in the ventilator-associated pneumonia among the adult trauma patients. This graph shows the internal concurrent data that we collected. It's over the course of 4 years. We initiated basically the bundle after 2018, and we see a reduction. We did a trend analysis, which in this graph, it was not statistically significant. However, the data points were few. So we looked at the data, TQIP data. This is a feedback TQIP data, which we received from the TQIP for our center. And over the course of years, we had the reduction in the ventilator-associated pneumonia. And in the spring of 2021, we were below the benchmarks of the TQIP. And we again did a John-Curie trend analysis on this graph, and we achieved the statistical significance because of the increased data points with the effect size of minus 0.9. In this spring of 2018, the TQIP rate was 5.24%, whereas in spring of 2021, the TQIP rate went down to 0.5. This was an 89% reduction to below the benchmark. The formation of a multidisciplinary committee with implementation of the ventilator-associated pneumonia bundle with rigorous oversight allowed for significant and sustained reduction in the ventilator-associated pneumonia. TQIP data and benchmark reports can be used to generate the data-driven approaches to quality and performance improvement with sustained results. And these approaches are standard for all trauma-related performance improvement initiatives from now on. Thank you very much. And I'm ready to ask questions.
Thank you. Any questions, comments, please?
I don't have that kind of data, like specifically which person's compliance with this was. This project was started before I started fellowship here, so I don't know if we collected those or not. Dr. Prabhakar maybe can help with this.
Joining us and for your this has taken the course of about 3 years to accomplish questions about money. Your question, the residents tell us every day when they get reminded, 1 month, 2 months, 3 months,
Any other questions or comments, please? Thank you. I'll introduce the last talk of the morning session. We'll begin by James Choi. His co-authors are McGurk, Sampson, and Dr. Latifi. He will speak about serial rotational thromboelastography in mechanically ventilated COVID-19 patients demonstrated hypercoagulability despite therapeutic heparinization.
All right. Good morning, everyone. I believe I'm the last talk before lunch, so I'll try to make this quick. I don't mean to be the gatekeeper here. So my name is James. I'm a PGY3 resident. So first, I'd like to thank the committee for allowing me the opportunity to present our work today. Our work is entitled Serial Rotational Thromboelastography, ROTAM, in mechanically ventilated COVID-19 patients. And what we wanted to show was that it does demonstrate hypercoagulability, or that ROTAM does show hypercoagulability in these types of patients, even under therapeutic heparinization. I have nothing to disclose. So last year in 2020, during the height of COVID, there's been increasing examples of hypercoagulopathic complications in COVID individuals. These range from DVTs, deep vein thrombosis, to clotted central venous catheters. But the evidence regarding how to characterize these hypercoagulabilities still remain somewhat limited. The goal of our study was to see how efficacious ROTEMs were in characterizing these complications in COVID-19 individuals. To do this, we conducted a prospective case series from March 2020 to June 2020, looking at 21 of our own critically ill, mechanically ventilated ICU patients that were diagnosed with COVID-19. We drew ROTEMs at 3 separate intervals. The first one on an average of about 21 days from the date of admission. The second ROTEM, about 1.5 days from the first ROTEM, and then the third ROTEM, 3.2 days from the second. Then we split up these 21 patients into several groups. The first major group was, of these 21 patients, how many of them had hypercoagulopathic complications and how many of them did not. The way we characterize hypercoagulopathic complications was really in 3 major sets. First, did they have deep vein thrombosis? Second, did they have clotted central venous catheters? And by that, I mean they needed to have 3 episodes or more of clotted central catheters. And then the third is, did they have a stroke that was radiologically confirmed? The second major category that we grouped these 21 patients in was, of those 21 patients, how many received therapeutic heparin and how many did not? And because of the serial nature of these ROTEM draws, we did a repeated measures analysis. Now, I just wanted to take some time to talk about how to interpret ROTEMs. I know for some this might be a little, well, it might be a little daunting. For me, it definitely was to begin with. But when, for us at this hospital, when we order ROTEM, this is essentially the results that we get. And to interpret these results, it's broken up into 3 major categories: extum, intim, and fibtum. And essentially, they correspond to the 3 major pathways of the clotting cascade. Extum for the intrinsic pathway, intim for intrinsic, and then fibtum for the fibrin activity. And then within each of those categories, we have these components. Now, there's a couple in there, and there's a lot of there are 1 or 2 that essentially correspond to the same thing, but I'll break them up into 3 major groups: clotting initiation, clotting time, and then clot strength. So CT, the first component here, is clotting time. Essentially, this is will tell you how long it takes for the clot to initiate. CFT, the second one, is clot formation time, which essentially tells you how long it takes for the clot to actually form. Alpha angle is a surrogate of CFT, or clot formation time. You have A10 and A12, which is amplitude at 10 and 20 minutes, and then MCF. All 3 of those, A10, A20, and MCF, all correspond to clot strength. But for us and in other literature, MCF is the more accurate one, so we use that one for our study. So again, just to reiterate, ROTEM has 3 major pathways: extum, that they look at extum, intim, and fibtum. Within each of those pathways, we have clot initiation, clot kinetics, and then clot strength. This graph is another way of those components to be represented. You can look at either one. So of the 21 patients, we found that on average, most of them were morbidly obese. The average BMI was 32.3. The majority of them, at least 76%, had fever-like prodrome prior to admission into the hospital. And then their average length of symptoms was about 5.2 days of these symptoms before they were admitted into the hospital. Now, these were our results. So to break this down, we have clot initiation in the first row and clot kinetics in the second row. In terms of columns, we have extum in the left column, intim in the right column. And essentially what I wanted to show here was, in terms of the extrinsic and intrinsic pathway in patients who had hypercoagulopathic complications versus those that did not, they were relatively more or less the same. There's really no big difference in terms of intim or extum pathways in terms of determining hypercoagulability. But interestingly, when we look at clot strength, So in patients with COVID-19 coagulopathies, we see that in the FibTum pathway, so the activity of fibrin, we see that their strength of their clot is incredibly high, at least more pronounced than those without coagulopathic complications. Now, here's the more interesting results that we found was that if we broke these patients up into those who had heparin drip versus those, or therapeutic heparin versus those that did not have therapeutic heparin, we see that looking at clot initiation on patients who had therapeutic heparinization, that their time to clot initiation was a little longer, took a little longer to initiate the clot, which if they're under therapeutic heparin does conceptually make sense. But when they actually form the clot, once the clot is actually initiated, patients with therapeutic heparin actually form the clot faster comparative to those that were not on therapeutic heparin. But the even more interesting result that we found was that the clot strength on patients with therapeutic heparin was still more pronounced than those without therapeutic heparin in patients with COVID-19. So in conclusion, we believe that ROTEM is an effective way of determining hypercoagulability in COVID-19 patients, specifically in the fibrin pathway, and that even under the effects of therapeutic heparin, that these patients still remain coagulable. Thank you. I'm happy to take any questions you may have.
Yes, Dr. Diefler.
Yeah, so, there's been one or two papers looking into the mechanism of COVID-19. And what we do know so far is that it initiates this hyperinflammatory response in patients. And it's believed that this hyperinflammatory response then initiates tissue factor, which then initiates this clotting cascade. So we think that that's that extra push that these patients have compared to patients without this viral infection that throws them into this hypercoagulable state.
If I could just add to James's comment, Dr. Diffler's question is exactly correct. I just want to congratulate James. So this was a paper that was done during difficult circumstances, and it has been accepted and hopefully will come out in print soon in the Trauma Surgery Acute Care Open Journal. But now, what we know about COVID is that it's probably more likely a global microvascular disease more than purely a pulmonary disease. So this topic is very relevant. Most people have shown already that many of these patients form clots and have PEs, strokes, and DVTs. The question is why, but the other question is how do you treat them? I think probably the most important finding from this study here is that heparin is probably not the answer because despite being on therapeutic heparin, these patients still had abnormal ROTEMs and still formed clots prevalent in the way they presented.
Any other comments?
Dr. Rocha, that's a good question. I don't think they've looked at other types of inflammatory disorders. Again, I don't no, I don't think they have.
Thank you, James.
Thank you.
Just a short announcement. The distinguished speaker, Dr. Raymond Price, will speak at 12:30. So meanwhile, we can have lunch served in the lobby. There are also tables outside. Thank you very much.
I think we're doing pretty good. Okay, I'm not gonna sing, don't worry about it, okay? It truly gives me immense pleasure to introduce our speaker, my friend and a friend of the globe. I was trying to figure out this morning what I'm gonna say about him, but I'm not very good in preparing what to say. I say what I think at the moment I'm saying it, so it's, Dr. Price has done some incredible things around the world, and we're going to get the tour of the world, of his world, and most of us long to do that. He's a vice chair for global health, Center for Global Surgery, and clinical professor of surgery, the Department of Surgery, and associate clinical professor, Department of Family and Preventive Medicine. Division of Public Health, University of Utah School of Medicine, Salt Lake City. He's a vice chair for graduate surgical education, Intermountain Medical Center, Intermountain Healthcare, Salt Lake City. Dr. Price is a true pioneer in global health, as he had expanded the role of surgery in public health, has helped improve health care worldwide. He's an amazing clinician, great researcher, author, and advocate for equality in healthcare. If you improve access to healthcare to someone, you just change that someone's life. That's really, that's that's the bottom line. And if we can do that, that's awesome. The president of Mongolia bestowed Dr. Price with the Presidential Friendship Medal of Honor and Dr. Price for improving healthcare of Mongolia on Dr. Price. He serves or has served on many leadership positions with the World Health Organization, Global Initiative for Emergency Essential Surgical Care, the Society of American Gastrointestinal Endoscopic Surgeons, and the American College of Surgeons and the International Surgical Society. He has helped guide and establish the Association of Academic Global Surgery. And I'm proud to say that we actually have one paper on his long CV. Matt told me yesterday that his CV is 47 pages. He said, Dr. Latifi, his CV is 47 pages. Matt, the quality of the CV is even more outstanding. I reviewed his CV again this morning, and I don't mean to embarrass Dr. Price, but I actually lost track of how many countries he have done work. It's just awesome around the world. Dr. Price, it's a true pleasure to have you here. And I'm honored to call you friend and a friend of New York Medical College and Westchester Medical Center. Please.
Thank you very much. And Dr. Latifi is actually one of my heroes in the work that he does, and actually have heroes around the world and the phenomenal work that they're doing. Thank you all for inviting me to come and spend some time with you. It's been wonderful to meet many of you and to see the inspiring presentations from this morning. It's exciting to see the young people come up that I think all of us older feel like are the people coming after us are probably a lot smarter than we ever were to begin with. And so I'm excited to see the people coming up. I've titled this talk, Adapt and Overcome, Reaching New Horizons for Global Health. And I want to start off with just a little bit of some basic principles that I've learned for successful global surgery work. And these may sound a little simpler than what you would have thought. But I think number one is remembering the overall purpose. The reason for which something is done or created, for which something exists. What is it? What is your purpose? What is the reason you do things? And do you remember what that is? Have you stayed with it? I ask my residents and my medical students periodically, do you remember the purpose? Not the goal. A goal is something different. A purpose, what is really behind your reason for what you do? And in doing global surgery work, you must have a positive attitude. If you don't have a positive attitude, you'll fail. Now, that can be true in just about any aspect of life. We're hearing all these research projects today, and you have to have a positive attitude that something's going to come from all that data that you're collecting. But then being versatile when you find something, to be able to be adaptable, being able to move and change. And I wanted to begin first with answering, where did I get my purpose? Now, my father was a trauma surgeon. He set up the trauma system in Salt Lake City, Utah with Life Flight. When he got out of the Air Force, I moved around the world as an Air Force brat growing up. And I can't remember a time that I did not want to be a surgeon. I always wanted to be a surgeon. I'd sit in front of the cartoon Saturday morning, get out Dad's books and draw little pictures. But one of them very impactful things was when I was called by our church, the Church of Jesus Christ of Latter-day Saints, to be a missionary in Thailand, 1978 to 1980. And I was home one day learning the language. Language is a little difficult. This says Pratet Thai or Thailand. It says Sawatdi, Khop Kun. There's 5 tones, ma, 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 ma. That's 5 different words. You caught those, didn't you? So 5 different words. And here you have, I think it's 48 different consonants. I can't remember, 20 some odd vowels to be able to learn the language. We were home one day and we're in an area here. This is Bang Na, Soi 101. Notice the homes have these fences around them, and they have actually shards of glass on top so people can't get over. We were home studying the language one day, and all of a sudden we heard this pounding from outside. We heard this screaming. And my companion and I went running out to the backyard, yelling across the fence, "Miaraga kuna, what's happening over there?" And the pounding stopped, but there was the screaming turned to a whimper. And really lots of people had gathered around the home, but they couldn't see inside there. But once the screaming stopped, most everybody left. My companion and I made a little ladder out of chairs, and we threw blankets over the shards of glass and got over into the other side. And there we saw what became the assailant jumping out of the window of the other side of the home into the swamp to get away. We found an older lady sitting in a pool of blood with her skull crushed in with brain material sitting there. She's vomiting up blood as well. We quickly couldn't find anybody else in the compound. It was all locked down. We carried her out to the front yard. How do we get her over the fence? Our white shirts were covered with blood, and we went to ask for help, and everybody scattered. Except our neighbor who knew us and said, "No, come and help. There's a problem." And they got a truck. There wasn't time to wait for an ambulance. We put her in the back of a truck and began to go looking for a hospital in Bangkok. The first hospital we stopped at took one look and said, "She's too sick for us. Go find another hospital." So we drove around a couple of hospitals, finally finding one that would take her in. As we were getting ready and washing up as the people were taking care of her, and remember, I'm a 19, 20-year-old kid. I'd had Boy Scouts, my first aid merit badge. Person came over and said, "So is this your maid?" "No." Is she a friend?" "No." "Do you know her?" "No, I've never seen her before in my life." And then the question, "So why did you help her?" Why did you help her? They put her in another ambulance. They had to take her to the government hospital. She died on the way there. I really began to make a commitment that I wanted to be in a position to be able to help people. What was my purpose? It was really coming clear. I was later called for 7 months to go up in the northeast of Thailand. And this is where I began to learn some of the techniques we use in our surgical work about capacity building. I didn't know I was learning this at the time, but our mission president called me and said, "Look, I don't want you to just be the branch president. I want you to train the first Thai person to be the branch president or the leader of our local church group." And so I had 7 months of trying to figure out, how do I transition the knowledge over to somebody to be able to help this little struggling beginning group grow. We had this little group. You can see how small it is at the time there. And I learned many things in working with the people up in that area. One was to listen and to learn what they have to offer and what they want. Have empathy to be able to put yourself in their shoes and be able to try to understand things from their perspective. And then from what you understand, use that to help guide your work. Develop friendships. By small and simple things can great things come to pass. And it takes time. Now, this is actually here with one of my best friends from high school. We just happened to be called to Thailand in the same place. We're working with this little branch, Boon Chui and Brother Tan here. And the monsoons were washing away the chicken farm. And I don't know, how do I save a chicken farm? Well, I asked Boon Chui, "What do you want to do? How can we help you?" well, let's dig a 2-foot ditch around the entire farm. And so we did, and it actually saved the entire farm. Brother Kuhn and his family, 6 children, his wife, were evicted from their home. How can you be versatile when you get evicted from your home and you have nowhere to go? Well, you get your other friends in the little local group there, and they got people together, and we went and cut down all the bamboo, and we made a 2-room house for this 8-person family. You have to be versatile. And these people taught me a lot about being versatile. And when I came home from my mission, I spent many years working with Laotian refugees. The dialect up in eastern Thailand is very similar to Laotian. So I was able to do a lot of translation and resettlement work with the Laotian refugees back in the United States. So when I applied to medical school in terms of developing my purpose, I stated this in my application: learning of the medical, social, economic, political, and emotional problems of the Thai and Laotian people increase my awareness of my own desire to be able to put myself in a position to serve mankind. It wasn't to go and just write another paper. It wasn't to get my name on some distinguished lectureship, but it was really trying to figure out how we can figure out how to help people get better care like they deserved. That little branch that we started, we're working with, Brother Bunyasaid was the first branch president. There was never an American that was in leadership there again. This was just a few years ago when they were starting the first, what's called stake. It's over multiple large groups, and they just formed a second one there. Over time, what can happen? Well, what are some of the challenges you face today? You know, we face many challenges back there in Thailand, and how do we get over them? Sometimes we think, hey, I've got a plan going forward, and it's going to be this nice, simple uphill ride, and it's not going to be too tough. But I found that in life, this is usually how my life goes. I have a plan, and then there's usually lots of ditches and ravines and all sorts of things that I've got to get across and challenges to face. So what I'd like to do is kind of use a couple case studies of our global surgery work. One of laparoscopy, developing this in low-middle income countries. Developing a center for global surgery in our own academic institution can be very challenging. Our breast and cervical cancer project in West Africa. Developing the World Health Assembly Resolution 68.15. We'll talk a little bit about that if we have time. The development of this current Association of Academic Global Surgery that we hope to finish the final stages of developing that this year. Laparoscopy in low-middle income countries. I want you to take a quick look at the picture that's on here. This was drawn by one of my Mongolian colleagues that gave this to me many years ago, as we spent many years at that time already bringing laparoscopy to Mongolia. Here you have 2 wolves. Wolves are very common in Mongolia. I'll show you that in just a minute. And you have the Mongolian flag and you have the American flag there. How do we transfer technological skills across countries, across cultures, even in our own residency programs? When I first was asked to go to Mongolia, there was a patient of mine had diverticulitis. He was running a foundation, and their foundation had decided to choose one country to see if they could make a difference. They were helping all sorts of countries around the world, but they'd chosen Mongolia. They were donating medical equipment to 39 different hospitals throughout Mongolia. If you remember, Mongolia was underneath the USSR, and when the wall came down in 1989, 1990, the Russians picked up, took everything off the shelves and left. It devastated the economy of Mongolia, and they were still struggling at this time. He said, what do they need teaching in? It says trauma. I was on the American College of Surgeons Committee on Trauma. So I came over there thinking I was going to be a knight in shining armor and see if I can teach trauma. I got hooked up with one of the residents. He had to put in a chest tube. This is when I asked him, I said, show me how you do it. Now, I didn't stop and say, oh, don't do it that way. I wanted to see how he did it. I wanted to listen, and I wanted to learn. We did talk about how we put it in afterwards, because after that, I kept calling him Chinggis Khan. I said, you were trying to assassinate that guy. We got to be very good friends, and we talked about how I might do a chest tube a little bit differently. Well, the first weekend I was there, Chuck Swanson called and said, hey, we need you to go wolf hunting with us in the countryside. I said, I've been in the trauma hospital. People are dying left and right. I don't have time to go to the countryside. I'm going to stay here. He said, no, Dr. Price, you don't understand. You are going wolf hunting with us. We have the president of the medical university and many of the faculty that are going out wolf hunting. So we went out to the countryside, and I'm not a hunter. Don't be afraid. I didn't shoot the wolf, but I did go along and learned how we chase the wolf in a Jeep down the countryside, banging around. The airbags blow off on the left side of the car. They don't even know that because they're shooting out the right side. As they're shooting out the window, they blew out Chuck Swanson's eardrum. The president of the Mongolian University is yelling, "Go, go!" And Chuck Swanson's saying, "Stop, stop, you're killing my Jeep, and I need to stop and take aim." And Chuck Swanson turns off the Jeep, and we come to a stop. President of Mongolian University, he didn't stop. He jumps out, he's got the walkie-talkie, talking to the other Jeeps, telling him where to go get the wolf. He turns to me and he says, "Stupid Americans need to learn to shoot from back of moving horse." That was very actually insightful. How do they're very good from the back of a horse. That story we told throughout Mongolia. It turned out to make more friendships with us around the country. We have maintained the friendship. And I can't tell you how much building friendships with the work that we do around the country is so important. Well, while I was at the trauma hospital, Dr. Segerlin from the university hospital called and said, "Hey, I need you to come over and hear what we're doing with laparoscopy." Again, I told Chuck, that's the stupidest thing I've ever heard. Laparoscopy, I see what they don't have here. I don't know how they're going to do that. And Chuck said, "Look, politically, you got to go talk to her." So I spent the last 4 days at University Hospital, and she gave me a very good PowerPoint presentation about why she thought they needed to have laparoscopy there. How were we going to do it, though? It takes so much effort here with the of equipment and supplies and training. How are we going to do this? And I don't know if you can see my look there. My eyes are covered up. She's telling me what to do. I'm going, "What are you talking about?" Well, she told me that in 1994, Buck Rusher, who's a Baptist missionary, came over for 3 years, worked with the people, helped start laparoscopic surgery there, brought Dr. Nimhu and Dr. Ganbold over to America for a month, went back, they did the first lap chole. After they did the first lap chole, they went out to celebrate, and they had dinner, they all got food poisoning, and Dr. Okandaya died. A little dangerous doing some advanced surgical training around the world. By 2005, when I came, only 2% of the gallbladder surgeries were being performed laparoscopically, and only in the capital city. I thought there were really many challenges to move forward with this. Even just the perception that MIS that people had that we shouldn't be teaching this in low middle income countries, or articles even written that we shouldn't be doing that. The poverty, the lack of infrastructure, electricity, water, equipment, just the language barrier. Nobody spoke English. What was the educational content we were going to use? Was there a business model to support it? And even just the lack of knowledge of the public that what is laparoscopy? They didn't even know what it was. And then I learned throughout our training, there's even much more of that. What about the quality assurance of the equipment you bring, the understanding of local regulations, the education of not just the doctors, but the nurses, the biotechnicians, the whole group of everyone that it takes to make laparoscopy work? What about the financial sustainability? You bring stuff and it just falls apart in many areas of the world. And then the political support, not just the political of the government, but what about the hospital leaders? You have to have support to be able to make this happen. Some of the misconceptions when we were working and putting on the Global Initiative for Emergency Essential Surgical Care meeting, we put it on in Ulaanbaatar in 2009. Beat Kier from the Swiss surgical team, who was doing a lot of teaching at many hospitals, specifically stood up and said, "You should not be teaching laparoscopy in Mongolia." We've been doing it by 4 years by that time. "You should be teaching basic open surgery." That was one of the major obstacles that we had. Well, we talked with Dr. Segerlin and trying to figure out what is it that she really needed. And we talked over the phone when I got home. What is it you want? Boy, she wanted everything. And so we came up with a didactic course that included lap chole, lap epi, lap hiatal hernia, lap colectomy, lap, you name it, we lapped it. And we developed a lecture about it. We got the equipment through the foundation, and I came over and was able to set up 2 rooms with the laparoscopic equipment, but we came with really a couple surgeons, 1 anesthetist, and a scrub tech. And we tried to do training in 2 different rooms, doing 6 gallbladders a day in each room. Oh yeah, that was not smart. So it wasn't smart because we had people surrounding us in the operating room, tripping over the cords and the wires and everything. Anytime anything got unplugged, they plug it back in and it blew up our light source. Or the sterility. I'm not sure how much you're trying to, we didn't really have enough equipment to do that many, to get it sterilized that fast. The equipment, they had sterilization in little small things. How was our equipment going to fit in there? The long laparoscopic instruments. We had to design new ways to sterilize the equipment. This is the magic box here. This is where formaldehyde is put in the bottom here, and you put things in there and it's supposed to come out sterile. I saw things come out in 15 minutes, 2 hours, 4 hours, 8 hours. I'm not sure whatever it was supposed to be. So we had a lot of areas of infrastructure to develop. And when people came in, nobody got any hands-on. Everybody wanted to get their hands on, so nobody got any sustainable change, even though we did lots of gallbladders. So we had to go back and think, wait, if we're going to do this, what we did this time was not good. The second week we were there, we did teach a laparoscopic colectomy to one surgeon. He is now the premier laparoscopic colorectal surgeon in Mongolia, having done over 2,000 cases. But we looked at that and thought, hey, we're having a difference in impact here. So we went back to kind of redesign our work plan. Our equipment wasn't just laparoscopic equipment. It was operating room tables, x-ray machines, even Dr. Bookwalder. We brought a Bookwalder to 6 different places throughout the hospital, retraction devices, and brought open instruments, brand new open instruments, because if my teams were going to be working there and we had to do something open, I wanted to make sure we were able to do it safely. We had to develop the education model, really revise that to very basic. We got permission from SAGES to translate the first 4 lectures of FLS, and then we developed the components for lap chole and lap appy, and that was it. We then did a multidisciplinary education team where we had 2 surgeons, an anesthetist, a scrub nurse, a scrub tech, a biotechnician, a research assistant, and then some support people. So if we went to one place, we had to have that team. And if we had 2 teams, they had to have that same kind of team. So we came up where we could teach, said, could we teach 2 surgeons? They're already surgeons. Could we train them? They've never done lap chole before. Can we take them in 2 weeks, doing 3 gallbladders a day? So that's 8 days, 4 days first week, 4 days the second week, and have them be able to go from assistant surgeon to only Mongolian, working with Mongolian safely. Well, Dr. Segerlin asked us to go up to Erdenet. And this gave us an opportunity to really study that and ask that question, because it had never been done there. Nobody knew how to do it there. And we went up to Erdenet with all the equipment, supplies, and everything, and started it. And then we compared for a year and a half afterwards the outcomes from Erdenet to the 5 hospitals in the capital where it was being done. We found there was no difference in outcome. So when she asked us to go ahead and now she needed help in distributing this throughout the country, she wanted us to go to the diagnostic treatment centers throughout the country and set it up. Our country is quite large. There are very few paved roads between these cities. They just don't have the opportunity to come to Ulaanbaatar to get this care. And their people have a high rate of gallbladder disease. So we felt like, yeah, we could begin to do that. So we came out with a program that required much more support. So we brought in SAGES to actually help provide some teams. I was on the Global Affairs Committee, and I went to Mrs. Stortz at one of the American College of Surgeons meeting, told her what we were doing, and she, over the next couple of years, donated probably $2 million worth of equipment that we took brand new equipment rather than used equipment. Bookwalder, Ethicon, Covidian, Megadyne, multiple companies that began to help with this project. You know, one of the cities out in Choibalsan on the eastern part of Mongolia, we looked at what happened over time with their gallbladder surgery. There's a Korean team that came in early 2009, did a bunch of laparoscopic cholecystectomies and left. They didn't get any kind of training or sustainable change, so they didn't do any themselves there. The yellow is the laparoscopic, the blue is the open cholecystectomy. The Swiss team came in. They actually taught some laparoscopic cholecystectomy, despite them telling us that we shouldn't. And still there wasn't a lot of that caught on, and we wondered why. And they actually had a right hepatic duct injury. And we talked with them. They were very nervous about doing laparoscopic surgery. They did not want to have the complications. Our team came in and with really an education model of trying to develop sustainable change. And you can see that the yellow line on average is really higher, but we had these nodes where there's nothing being done. Again, the entire team, it didn't do anything right after we left because the nurse in the operating room left just for a trip. And when she came back, they could do it again. Or the other times when the sterilization machine went down, they had to ship it 16 hours to the capital to sterilize the equipment, or when they were developing an operating room. trying to understand the whole infrastructure of what you're trying to develop is extremely important to make long-term sustainable change. What about the long-term sustainable development? And I went to Mrs. Storch and I said, how are we going to maintain your equipment? You don't have a company in Mongolia. She said, I got an idea. Let me send my representatives from Moscow and Irkutsk down. They came and taught with us in Hovd, which was way out west. And then when they got back, they set up a distributorship in Mongolia. Here's them showing the people how to actually order the products online in a cost-effective manner for them. And they begin to then develop what's the business model needed to support this. We eventually set up some of the surgeons to be a distributorship for Covidian. They set up their own business to run that as well. What about training? So we were training doctors, not necessarily the residents initially, but how are we going to maintain and replace the doctors if they were to leave those areas? Well, we need to get into the training program. So in 2009, we started our Train the Trainer program. And here we have Dr. Erdene. Dr. Erdene became the director of laparoscopic training for the university. He had developed his own fellowship for 6 months for the people that come from around the country. The surgeons would come for actually 5 months initially, and then the last month the surgeon would be there and their nurse and scrub nurse would come and train with them as well. And so that our training programs expanded by having the Mongolians go out and train in many parts of the country. In 2009, we set up a training program where we connected the operating room to a auditorium. So 100 people could be here watching a laparoscopic case. We had two-way communication. They could see with inside the laparoscopic view as well as the operative view. And I had that in 2 different rooms. Came back in 2015, and one of the surgeons said, Ray, come see your vision. So what do you mean? They took me over to this hospital and they showed me their new laparoscopic training center for their academic program. Residents would spend at least a month there practicing on the FLS kind of skills. They had the flat screens connected to the operating room, and they have really, truly a laparoscopic training center. Dr. Erdene, who is this director, when we asked him that we wanted to broadcast our low-cost laparoscopic device from outer Mongolia, I thought this was crazy. How are you going to do it with internet capability? His only comment was, Dr. Price, I only know, he'd say it in Mongolian, I only know 3 words in English. Yes, okay, no problem. I haven't had the heart to tell him that's 4 words. But his positive attitude, and this is what I learned from the Mongolians, is extremely important. We were traveling out in the countryside with one of my scrub techs. And there was just me and this 19-year-old scrub tech and Dr. Hagwa, colorectal surgeon. We got lost. She began to get nervous. She finally asked Dr. Hagwa, if we have car trouble out here, what do we do? He looked at her just dumbfounded and said, well, you just fix it. And I think that's the kind of attitude with global surgery we have to have, is we just fix it. Well, one of the problems was it's a government-funded healthcare system. It was the hospital director here, that said, hey, Batushin said, can you go on live call-in talk show for Mongolia and talk about laparoscopy? And I thought, what are you talking about? He told me, he says, we are not going to get the government to fund this unless we let the people know what this is about. And we have to educate the public about the importance of this, about being able to come in the hospital and go home soon and get back to work. And until the public starts to demand this, we will never make this sustainable. It was at that point, from then on, every place we went, the local dignitaries were invited in the hospital, the news reporters, they come in, interview the patients. And so as a national public health campaign in trying to teach them about what laparoscopy was. I sent my wife, my anesthesiologist, and my resident out and said, please go get the story of this patient of ours. She was 24 years old, had a laparoscopic cholecystectomy. This is her 4 days after her operation, milking her horses for her milk tea, making her yogurt, taking care of her family. This was taken to the Ministry of Health. It was taken to Mrs. Storch. It was taken to funders around the world about why this is so important for people where 45 to 50% of the people were still nomadic at the time. What happened over this time? In this chart and graph here, the blue line is open cholecystectomy. The red line is laparoscopic cholecystectomy. By 2011, laparoscopic cholecystectomy began to be the primary way to remove the gallbladder in Mongolia. It's now in over 80% of the population has it this way. It's in 19 of 21 provinces currently. Our teams, as early on, taught in the purple areas. I've been in some of the blue areas, but most of those blue areas were taught by our Mongolian teams that went out and did the same kind of training. And so that it's had a dramatic impact for the entire country. This was the low-cost laparoscope that we developed at the University of Utah, saying, well, Mrs. Storz is not going to be able to donate equipment for us forever. This little device here is this replaces the light source and the camera. It is the $1,500 kind of component. This part is about $100. It's supposed to be a disposable unit, but we've used it 25 times in a row in Mongolia. And this is what we did broadcast around the world that we showed that could be done in a low resource area. And so here's the nice story from this last trip to Mongolia. We had went way down to the Gobi Desert, down to Dalanganzad. Here we met this patient. And this patient was from 2011, where this surgeon did an open cholecystectomy on her. She's holding her gallstones. She was very proud to bring her gallstones out and show us. This in the pink is her sister, who the day before this picture, the same surgeon who had gone up and done the fellowship with Dr. Erdene did a laparoscopic cholecystectomy on her. And then we drove her back to her home out here in the middle of nowhere, and she's back out with her sheep really within a day or so after her surgery. I think this is the kind of long-term sustainable growth that we're talking about in global surgery work. So that now there's a big laparoscopic surgical society in Mongolia where there was nothing just a few years back. What we learned with training minimally invasive surgery here, it wasn't just about teaching a technique or a technology. It allowed us opportunities to find new financing mechanisms. It provided an avenue for poverty reduction. It stimulated infrastructure development. It actually decreased brain drain. When you can develop the equipment and the infrastructure and provide the training education in the same site, people don't leave. They stay in the same area. It's an opportunity to treat a broader range of diseases. It encourages affordable, high-quality innovations, improves universal health coverage, and essentially, it's a way to strengthen the healthcare system. And I think that's what surgery does, and we need to have more research and education of our own country of the impact surgery has on the healthcare system. Well, I'm going to jump over our Center for Global Surgery that we began to develop. The Center for Global Surgery, well, this is our vision. We envision a world where safe, effective, and affordable surgical care is accessible to everyone. Still haven't lost our purpose. This is what we're trying to do. Doesn't matter what country you're in. I think the university is an excellent place to do that. You have medicine, you have engineering, you have social work, you have public health, you have all these different areas. Can we combine these together and figure out what we do? We combine that into a conference called the Extreme Affordability Conference, where we brought in business, public health, engineering, and surgery, asking the questions, how do we make this affordable? And so I think it's truly an opportunity. We started our center in 2011, and it sounds like nice and easy, but what happened? When I first went to the chairman, Sean Mulvihill, and said, hey, we need to have a Center for Global Surgery. And he said, go talk to Catherine DeVries. She does that same kind of work. He actually said she does that touchy-feely kind of stuff. Wasn't quite the response I wanted. So I got with Catherine DeVries, pediatric urologist, phenomenal lady, who set up International Volunteers in Urology. They teach all around the world. She's just amazing. And we got together, we each gave grand rounds at the time, and we began to set up our Center for Global Surgery, and we sat down and thought, well, what's the problem we have? We have misperceptions of what people think a Center for Global Surgery might be. Oh, is it surgical tourism? It detracts faculty from RVU generation. I mean, what is Dr. Mulvihill thinking? It's expensive, unfunded projects, non-academic. Maybe it's just volunteerism. Maybe it's just a vacation activity. We found out this is what perception was. Our perception was, no, how about research and clinical fellowships, a journal club, large multi-institutional grants, and maybe even philanthropy input of financial resources, global surgery course, exchange programs, international rotations. So our perspective was much different what was there. Now, how are we going to change that? Well, we had to be able to figure out what is the value of this to the institution. You know, the institution and it likes about teaching and education, about research or discovery. They want advanced health, but they need to look at the cost. It has to be cost effective. So the value to the institution, how are we going to develop that? So as we started to look at a Center for Global Surgery, it was 2007 when we first asked that question, and we're kind of turned away. But we went ahead and started a global surgery interest group at Catherine's home and invited anybody interested in this kind of concept to come and discussion where we put these ideas together. We then, in 2008, the American College of Surgeons was struggling in Salt Lake. They needed a meeting, and we said, well, we'll put one on. It was the best meeting, still the most attended. We actually sold out, all on global surgery. And then we said, well, what can we develop? We have to develop some academic things. This is where we began a course called Global Surgery and Public Health. It was the first one in the United States. We still teach it today in this winter semester. And from that, I made the stupid suggestion to Catherine, we have all this information, maybe we ought to write a book. It was a joke. Catherine didn't take it as a joke. And so we worked on writing this book, Global Surgery and Public Health, The New Paradigm. We then begin to look, well, we need peer-reviewed publications, national presentations, book chapters, posters, surveys. You know, we surveyed the work in our departments, what was already being done. So when we went back to the Department of Surgery in 2011 and made a presentation of the academic work, the scholarly work, the financial possibilities, the interest of the residents to be able to participate in this kind of work, we got first our initial funding for the Center for Global Surgery. We then began to add more things, this Extreme Affordability Conference, trying to be an inclusive working group within the university to bring out these ideas of low-cost innovation. We started our Global Surgery Fellowship and continue to grow that. Medical student global surgery interest groups, visiting scholar program. We developed MOUs with Ghana and Mongolia, where many of us have been working for many years. And then one of the big things, the next step was developing in-country support people. Our director of our Center for Global Surgery in Ghana is now in Ghana at the Ensign College of Public Health. I've been able to develop resident rotations there. And then over this last time, these three little things is the beginning of our endowment. First was 100,000, another 120,000, then $1 million. And so we're shooting, trying to get 30 million in endowment to be able to support it, but we have about 1.5 million now. And then trying to broaden it so it's not just surgery, bring in other departments, OBGYN, we're talking with anesthesia. Can we better develop this into really not just a center for global surgery, but maybe a center for global health? These are just many of the books and chapters that we've written to be able to try to bring this to the forefront of academic surgery. And our programs, as we found, many of these were ongoing. We've been supporting, many of them have developed since then. In fact, many that just aren't on here, such as our cardiac surgery programs or our liver transplant program. They've got a grant where they're partnered between Mongolia and our program now. They give lectures every 2 weeks to each other. But we have laparoscopic expansion programs, international advancement programs, cleft palate, the pediatric surgery operative training program, neonatal pediatric hearing loss, all sorts of programs where people are working on around the world. So our Center for Global Surgery is one where we really think we want to be making a sustainable difference. It's not about just doing papers, not about building a name. It's really making a sustainable difference. We hopefully define the problem, explore solutions, measure our impact, train global leaders, build surgical capacity through innovation, research, and advocacy. So our breast and cervical cancer in West Africa, a horrible problem. Stage 3, stage 4 disease is the way that women really present there most often. I've had very close friends that have had this over there and a difficult time getting the care that they need. Breast cancer is the leading cause for cancer-related deaths among women in Ghana currently. And as you see here, I put this picture because the women have such an impact on the economy. They're out trying to sell, to support their families. They're working constantly. It's an extremely important area in resource-poor areas of the world. So we began trying to look at the problem. I had a very close friend that I met over there that ended up in the United States, and I took care of her here in the US because she just couldn't get the treatment there. And it caused us to begin to look at this. Now, challenges, our chairman in the Department of Surgery has been very supportive. When we told him we're going to look at breast cancer, he said, really, you're going to waste your time. It's too big of a problem. What are you going to do? And that made me decide, okay, we're going to do it. You're going to tell me no, we're going to go ahead and do it anyway. And so we began with a little $5,000 grant to do some little teaching programs with a little district area. We brought in the 50 community health workers, actually 49 of them came. And we did a training program on breast cancer and learned about their misconceptions of breast cancer. Especially, you look at things like this one here. 50% of them only said it was false. If a man sucks a woman's breast, it may decrease her risk of breast cancer. Who came up with that? It certainly wasn't the women. When you over here, breast cancer does not affect men, it affects only women. After the training, that knowledge becomes much, much better. And these are the people that are out training the local people in their communities. As we went on and got a $25,000 grant, worked with our public health group, went out and did surveys of trying to really understand the public's perception. They're not familiar even where or how to seek breast health services. They believe that breast cancer is a death sentence. You know, back to our anxiety about going to a cancer hospital, they have real anxiety going to the hospital because their thought is if they go to the hospital, the diagnosis of breast cancer, they will die. They believe in a variety of potential causes of breast cancer, not supported by evidence, such as they concern that breast cancer is an infectious disease. So if they get told they have it, they don't tell anyone because nobody will want to be around them. Well, this aspect of where to seek breast health care services is one that we thought, well, both at the School of Public Health in Ghana and the Ghanaian Health Services were very interested. So we came up with a comprehensive nationwide assessment of mapping of breast cancer services and actually adding breast and cervical cancer. And one of our fellows was from the Gambia, says, I want that for my country. So we began to do that. Usman, who was our fellow here, phenomenal, actually good surgeon from the Gambia, he went ahead and organized the research assistants and the going out to really assess the entire country of the Gambia. It's small compared to Ghana, but we ran into problems. Now, you may have had newspaper articles like this too. Back on March 13th, you would have thought the sky was falling. Our governor limits mass gatherings. The LDS Church suspends meetings, suspends world meetings. Testing ramps up, but local and national concerns linger. Sessions of tough issues under cloud of COVID-19. More importantly, Donovan Mitchell got COVID-19. Rudy Gobert got shut down the NBA. NCAA tournament was canceled. Stocks have worst day since 1987. I just go on. Disneyland closed. That almost affected more people than anyone else. You know, if Disneyland's going to close, we know how many people have died, how many people have been sick, and we've had to deal with this now for the last, you know, many months. But this is what we were faced. As my fellow was over in Ghana, it was about 3 days before this article when I finally pulled him out and said, "Get on a plane and get home." So my fellow for this next year, her expectations, she was our first one to get a Fulbright scholarship. She was going to be in Ghana, really working on these projects. She was so excited. What was the reality? She has never been on the ground in any of those places, but we had lots of Zoom meetings. She's been in contact with Ghana constantly. And so what happened with our program? Adapting and overcoming, okay, training of research assistants in February last year. We started the surveys, both in the Gambia and completed it. Then in Ghana, we went ahead and started it, the Eastern region, doing the preliminary area. But in May, complete shutdown of the program. Even with our in-country people, we had to shut it down. We evaluated the Gambia data, and this is what my fellow began to do. Begin to work, look at the Ghana pilot and to get things set up to do the nationwide project. Survey was updated and we got the IRB reapproval in November 2020, and we got permission then to move forward in December with our research assistants, and our fellow went ahead and developed 7 training videos to teach the research assistants again and do the hands-on training with the people who were doing it before so that we could get that up. And we've nearly completed the entire country of Ghana despite COVID happening in this last little while. The information that we've been able to put together when we look at the Gambia, as we look at the various hospitals, what's available in terms of screening, diagnosis, and surgical management of breast cancer. And what we hope to present to the Ministry of Health by September of this year is this kind of information where if we add just some other basic services in 2 hospitals, we can improve the diagnostic and surgical management availability to a larger percentage of the population in the Gambia. In the eastern region of Ghana, we found that no site even reached the level 3 NCCN basic guidelines for low resource areas. So we came up with another stratification system that at least identified about screening, pathologic diagnosis, and surgical care in different areas so that we can begin to develop the next stage to hopefully get to the NCCN basic area of services. There's some other challenges. You know, we thought we're doing pretty good. We've partnered with the Ghana Health System. We've partnered with the Ensign College of Public Health and KNUST up in the center part of Ghana. We had letters from the Ghanaian health system to each hospital in introducing our research assistants. But there's challenges that we still met. The 6 teaching hospitals all of a sudden required separate IRBs. They also wanted $1,000 at each one. They also said, we want 3 or 4 of our faculty to be on the paper. Because we had an in-country director to be able to work with these people, we've been able to solve those problems and move forward, and we're nearly completing all those hospitals now. I wanted to represent this one, misunderstanding purpose and scope of the survey. There's a Catholic hospital, it's a Catholic and public hospital that is doing phenomenal work with cervical cancer. But the gynecologist there was very nervous that maybe we were coming to steal his data. Now, we were actually very interested in what he was doing, but it wasn't the data that we were trying to go after. And to solve that, we then got Zoom meetings so we could talk together and figure out what it is. And he sent me lots of WhatsApp messages over this last week. This is one of his. Locals must understand that collaboration is important, but we, the Ghanaians, do not have to wait for support from outside to solve our problems. And he's gone on to explain problems he had where people called his teams lazy Africans that they broke off the partnership with. I found many areas where the way we have worked with people has caused us problems to be able to do the work that we need to do. So challenges that we need to do is to overcome, sometimes we create ourselves. The World Health Assembly. How many of you heard about the World Health Assembly? 68.15, or even know what that is? Anyone? So I had a friend of mine about 7 years before that call me and say, Ray, we need to get surgery on the map so that governments will fund this. We have to get a resolution at the World Health Assembly. I said, great, how you do that? He says, well, you know the Minister of Health in Ecuador and in Mongolia. Can you get them on board? I'll get Nigeria and he had another country. And we were very naive because what we learned is there are 36 members on the executive board elected at any given time of the different countries. And they're the only ones that can actually propose resolutions. So you have to get them interested in it. This came about as an interest because both of us were working with the WHO and the Global Initiative for Emergency Essential Surgical Care Project. And this was really the first coordinated effort to address the absence of adequate capacity for emergency and essential surgical care services in low and middle income countries. It's going all around the world. And in 2008, this is what we finally got. The World Health Organization finally added surgery as an integral component of primary health care. Now, it's an integral component on the outside. It's not on the inner circle here. So we still had a lot of work to do. And this is where Adam Kushner called and said, we got to get a resolution. Well, he went and talked with our representative from the United States. What did our representative say? If anything like this comes up, we will veto it. All we're trying to do is say surgery is part of universal health care. We'll veto it because the World Health Organization is so cash strapped, we can't ask them to do anymore. So we're not asking them to do anymore. So then began an advocacy campaign. Again, here you got a challenge. Are you just going to give up? Or are you going to keep going? And so what we began to do, our Center for Global Surgery started sending letters to everybody that had any interest in global surgery and other academic programs to write letters to our representative. At the American College of Surgeons, Kathleen Casey, who set up Operation Giving Back, that's where we learned about the 36-member executive board. I was chair of the International Governors Committee at the time. We invited all the governors from the 45 different countries. We looked at which ones were on this executive board. How can we reach their representatives Australia actually wrote 4 different types of resolutions for this. And then we went to the American College of Surgeons. Can you write our representative in support of this? And so Pat Newman helped us get this on the agenda for the governors, the regents, and the International Surgical Society presidents meeting, and said, yes, they're all in support of this. And Kathleen and I wrote this letter that then all these people signed. We respectively request that as the United States delegate to the World Health Assembly, you strongly advocate for the concept that the development of healthcare systems for any nation must include access and support for appropriate surgical care and anesthesia in equal relationship to other critical healthcare components. What was the response the American College of Surgeons got? Thanks, but no thanks. We then got a sign-on letter from both the Republicans and the Democrats. They got a letter back, thanks, but no thanks. Is when I was traveling to Trinidad and Tobago for another meeting with the World Health Organization, I met Mike Levitt. Mike Levitt, anybody know Mike Levitt? Mike was our governor in Utah. He also then became the director of the EPA and then later the director of the Health and Human Services. He was also my kid's baseball coach. Use whatever connections you got. So I went up, Mike, we're having trouble with trying to get the US to support this, and told him all about it. We're sitting in the airport waiting to catch our different flights. He said, Ray, you don't need the US. What you need is the African nations. If you get the African nations to come on board, the US will look silly and they will come on board. My trip down to Trinidad and Tobago was just very opportune because this is where I met Emmanuel Makasa. A chief resident from the Mass General came up and says, have you met Dr. Makasa? I said, no, let me introduce you to him. He's from Zambia. And in fact, he was the leader of the permanent mission of the Republic of Zambia to the United Nations office in Geneva, Switzerland, and actually was representing a large number of African countries. He's an orthopedic surgeon from Zambia, became very interested in our work, and he was able to take it to the finish line and get that resolution and through all the different processes supported by the African nations. And guess what the US did? They came on board and co-sponsored it. So in 2015, phenomenal resolution, voted 194 nations, all nations voted unanimously that surgery is part of universal healthcare and gives directives to the various countries of things they can do. It's what Harvard is working on in developing national surgical plans with people around the world that stemmed a lot from this resolution. Just even in our own country, things are beginning to progress. There is a Congressional Global Health Council briefing book that is presented to Congress every 2 years when the representatives change. First time in 2019, and it's in this one in March, a specific section on funding global surgery. And in there, it tells our Congress people, the World Bank has identified essential surgical care as one of the most cost-effective health interventions available and a health priority that is within reach for countries around the world. Building surgical capacity benefits an entire health system, empowering the health workforce, stimulating the economy, and contributing to healthier, more productive populations. Now, it's important right now, in fact, to garner support from everybody here, because we've had people working at our government. We have USAID, where we finally got support language into their report of the current budget. They took out the line item of the amount of money for it, though. And so we're working hard to try to get $100 million to support this wording in the current USAID wording. And so over this next few weeks, it's going to be important to get this in. We've been working for years to get the American College of Surgeons to work with us on the advocacy on global surgery at our national level. This year, they finally caught, as we presented this to Christian Shelgin of the American College of Surgeons, really got on board so that the ACS actually put out a letter, and they got 16 other 16 other societies. They led a coalition of 16 surgical organizations in sending a letter April 28th to the leadership of the respective House and Senate subcommittees on state foreign operations and related programs, urging inclusion of $100 million for neglected surgical conditions. This is the way the HIV funding started. Start small. By small and simple things, great things come to pass. You can go online, you can look up Surgeon's Voice, and as you look up Surgeon's Voice, you can, through a few clicks, you can send a letter to your representatives supporting this wording. and it's very easy to send out very quickly. Look up Surgeon's Voice. Encourage you to help us out with that. Last thing, for a couple slides, is the development of the Academic Association of Global Surgery, the Association of Academic Global Surgery. About 4 or 5 years ago, I was getting many questions of how to set up a Center for Global Surgery in different academic institutions. I was getting calls from different department chairs around the country. Why should I let my faculty participate in this kind of work? What's the benefit to us? And we had lots of discussions, and we thought, we need to have something to support the growth of academic global surgery. What does it mean to be a fellow in academic global surgery? What does it give them credentials to do? Is there any standards to help them get the jobs? How can they use it? We wrote an article in 2030, really kind of looking at what are the roles of surgical colleges and academic medical centers, trainees and training programs, academia, in building sustainable, resilient surgical systems. So over the last few years, we've been working, we put together 2 committees about 2-3 years ago, an education committee and the committee to develop the guidelines to run the committee. Education committee didn't function so very well then, but the other one, the Rules and Regulations Committee, really took off. Chris Dodgen, Nia, a good group of young surgeons have really helped us put this together. And we now have our vision, our mission. We aim to establish academic approaches in global surgery to reduce surgical healthcare inequity worldwide. Our objectives is to engage and unify academic global surgery, to cultivate and refine the teaching and administration of global surgery programs via partnerships and innovation with similar organizations globally. We support global surgery programs in developing equitable bidirectional collaborations, and we develop the next generation of compassionate, capable academic global leaders in surgical education, clinical care, research policy, and advocacy. In fact, we've gone ahead and formed the organization that, we're actually taking this next month, self-nominations and other nominations for president, vice president, treasurer, recorder. We're developing the leadership council where we have 2 representatives from the academic institutions that wish to join. They'll form a leadership council. There are committees that have been already formed. We formed 9 committees in October. They've been meeting every 2 months and developing a product going forward. And we've just added 6 more that are coming on board. It can be up to 15 members on these committees. We have 137 active members and about 86 associate members already, and trying to grow the support of academic global surgery, not just in the United States, although 85% of our members are currently from US or high-income countries. We'd like to do this worldwide. So, in summary, successful global surgery, through the examples I've shown, understanding what your purpose is and not being turned away from it, having a positive attitude, and being very versatile is going to be important for any kind of global surgery work. It's important for the academic work we do in anything else. Sometimes I think we focus on, oh, we got to find the right partner, and we do, but you find the right partner by being a friend. So the tenets is to listen and learn from the people you're developing these partnerships with. Really have the empathy, learn what they are going through, learn what they want. Try to use that information to help guide your work. I went to teach trauma, and then I ended up teaching laparoscopy. I didn't come back and share with you, we've now set up ATLS in Mongolia. That's a whole nother story of all challenges that we had to overcome and still continue to overcome. Building friendships, going out wolf hunting, deer hunting, marmot hunting, playing golf, there's only one golf course in Mongolia, we've gone bowling, we've played soccer with the entire staff that we're teaching. They recommended it, and it became a phenomenal tool in what we did. And then time. This is not just a one stop, here we're going to help you one time. It's a long-term investment that we make. I don't know if any of you saw the movie called The Art of Racing in the Rain, but I think this picture depicts what I sometimes feel about global surgery. I can't tell you how many times I invited a friend, came out to Eastern Mongolia, a great guy. We came back to Ulaanbaatar, and he said, Ray, thank you for inviting me to come teach laparoscopy with you. I now am convinced we shouldn't be doing that here. Tell me why. Well, he'd written an article I didn't know 10 months earlier saying we shouldn't be doing this. And he said, well, they don't know how to put in a chest tube. They don't know sterile technique. I said, you're right. But laparoscopy got you into their operating room. So did you teach them how to put in a chest tube? Did you teach them sterile technique? Oh. What did you learn from them? And so we had a discussion of, people like to put up a storm out there. I see so much negativity these days. And I think we need to look for the positive. And I think this shows this. Even in the middle of a rainstorm, there's a bright spot, and we need to be able to see that. The below average drivers crash. This is from the movie. The average drivers quit, but great drivers push through and push on. It takes patience and courage and even grace to persevere. And I think that's true in a lot of what we do in medicine. I need to end by thanking my wonderful family. We've had 9 children. We've had challenges. My first son passed away 2 months old when I was a resident from sudden infant death. My 36-year-old, who became severely handicapped 6 months later and was left like she was 6 years old, took us back to Salt Lake so that I did not do the fellowship that I had planned on doing because we had to focus on the family. She passed away this last year of metastatic colon cancer that was just unsuspected, diagnosed and passed away 3 weeks later. Another daughter here that has a severe MS and is really struggling, and several with mental health issues, I think because of my handicapped daughter. We don't give up. My children have gone with me to work with me around the world. A lot of the pictures you've seen here is because they've taken them as photographers. They've worked with us around the world and are very supportive, and we can always bury our head in the sand. But the global surgery work, there are people out there who need adequate health care. They don't have it, and we need to figure out a way, whether or not it's in Ghana, Mongolia, downtown Detroit, downtown Salt Lake City. There's so much work that we need to be able to do to really help our patients, and I'll leave that with you. So thank you very much.
Wow. Dr. Price, that was absolutely awesome. As we expected, it's going to be inspirational. It's going to be, they in Texas, they have a say that you feel lower than a snake's belly. When you see this, what you have done around the world, I feel this tall, this tall. Let me see if anyone has a question or comment. Dr. Babu.
When you went in, you obviously had a lot of, I would say, negative things and obstacles, etc. So how did you really overcome that? Because there sometimes you really cannot, if there is deep suspicion that your purpose is actually challenged. Did you give up some time because of really terrible political and geopolitical problems, or did you continue to persist? You obviously did a remarkable job over the years.
It's a great question. As we published an article, the first 50 lap coles from Kumasi, the second largest teaching hospital in Ghana. There, it was a different situation. We didn't have really good support from the hospital leaders. Surgeon had some little challenges, would hide the instruments in his office so nobody would steal it. Yeah, we had an anesthesiologist from the University of Utah, bless his soul, did a great work in Ghana for years, passed away just recently, complained of something that he did, and it caused the surgeon not to be able to operate for 2 years and shut down laparoscopy totally in Kumasi. And so we had really challenges there. We've looked for other places. Cape Coast is another teaching hospital where we've really gotten some great partnership there. So yeah, I think and even going to Mongolia, I went there to teach trauma, and I mean they needed it. The first patient I was introduced to there, a lady lying in the hallway on a stretcher, said she came in 2 days ago, bad accident. We're starting to feed her, and she's doing better now. And I looked down. I said, I don't think she looks so good, and said, what's her vital signs? And they said, got the nurses, and they said, well, 2 days ago they were. I said, no, what are they today? And the heart rate was 140, and the blood systolic was 80. And so we picked up her gown, and she had the worst seatbelt sign I've ever seen, both across the chest and across the abdomen. And her belly was rigid. I said, no, she's either got a ruptured bowel or a transected pancreas. Oh, no, she's doing fine. So well, let's get an x-ray. Well, we finally got a CT scan. They said, okay, it's going to cost you $50. Wait, I just fixed, my engineer just fixed your CT scanner. You're spotting me a CT. So we got the CT, and they came running 2 hours later saying we got free air all over, and she'd ruptured her bowel. But they still felt like trauma was something they did well. As we taught laparoscopy throughout the country, they then came back, the Mongolians, said, we have a problem with trauma, as they saw people throughout the country lying in beds, not being diagnosed appropriately, not being treated appropriately. And they came back and said, we would like to get trauma training. And in fact, after I gave them the inexpensive ones, they came back and said, we want the advanced trauma life support course. So it may take time. I mean, this is now, that was 2005 when I went there. It was 2014 when we began to do ATLS training. And it's taken us up until now that they finally have all their instructors that can teach ATLS. So you have to sometimes make a diversion and come back. Sometimes you need to go to a different spot. You have to be adaptable, versatile. It's one of the things.
I absolutely agree. That's a key word. And Faisal, you'll be next. When we went to Kosovo to do the telemedicine program, I had to spell the word so many damn times that I hated it. Tele what? What are you gonna do? Telemedicine? In those days, Skype was just coming up. Oh, you're gonna do Skype, huh? So the day we signed the memorandum of understanding, my adrenaline just dropped. I was absolutely exhausted. I was physically exhausted, emotionally exhausted. I missed my family. I said, I'm going home. And some of you maybe heard this story, but there's someone saved me. I called a friend of mine. I said, I'm going to come and see you at 2 o'clock in the morning. She goes, what the hell you do want to do at 2 o'clock in the morning? I said, you know, I'm just having a bad day. Just come over. So I hopped in a cab. Our program was in the media constantly. So your comment to be on the media, it's absolutely key, because those, I couldn't use some really bad words here, who lead those countries are not always the nicest guys in the world, but they do succumb to pressure. And a public pressure works. So I've been on TV a lot by this time. So I get in a car, sit in the back, and the taxi driver, I don't know his face, but I had seen the mustache on his mirror. He said, Dr. Latifi, oh my God. And he's so joyful because, you know, I saw you on TV today. I don't know what that means for our country, but really sounded great. I'm so glad you're doing it. Can you quit after that? Hell no. No, you don't quit. You just keep going. But yeah, you get bruised and wounded. Sometimes you risk your life, but you keep going. You don't stop just because, you know, there is a little mud of water here. Just go around or jump. Faisal.
Thank you, Dr. Price. It was an incredible lecture. Thank you so much. We learned a lot. I think the 2 key things that I took from your lecture was the emphasis on the word sustainability. I think that is one of the most important things which you want to see in a program that encompasses global surgery. You just don't want to make an impact and leave, and then you leave and the whole things go back to point zero, square zero. and all you were able to do was just a few months. But I think the emphasis on how even when your team left their place and that thing is going, that is so incredible. So I would just like to get some pointers how you work on that sustainability factor of that. And the second most important question I have is that how do you include the local people in this? Because some of the local surgeons, they may take it that you are hijacking their privileges, or you are hijacking what their role in the community is. They are already worshipped like a people there, and you go in there and all of a sudden you get all the limelight and you get all the publications. So how you make sure that the local surgeons who are going to be long-term present there, you involve them and you give them a feeling that they are equally a part of it, and this whole thing is not hijacked from them. Thank you so much, sir.
Both those questions are quite important. And the reason I started off with a little bit of the story from Thailand is because of that sustainability. How do I, as a leader of a local church group in ours, you're responsible to helping with their emotional needs, sometimes with financial needs, sometimes they don't have food. And how do you do that in a very resource poor area? And how do you train somebody to go in that role when they have never thought about doing anything like that before? And you have to give them experiences. We talk about in surgery, we have to have our residents have an opportunity to operate independently, feel like they can do it themselves. And I think those concepts are extremely important. In Mongolia, for laparoscopy, we always set it up that I was never the primary surgeon. They'd come and say, can you come do this case for me? Can you come and operate on me? People would come to the hotel. They'd be coming everywhere. Can you operate on my family member? And it's like, you talk to Dr. Segerlin or to whoever's leading that one that time. You talk to the Mongolians. They're the ones who are organizing this, and we're happy to help them do their surgery. So it was never us doing the surgery for them, but we would be happy to help their surgeons because we didn't want them to think, hey, well, there's an example down in Belize. I went and did a visit down there. We actually put an ambulance together and took it down to the southern province in Belize, in Punta Gorda. There's 4 provinces. And down there, as we went there, we learned of a group that came from the United States. They come once a year. They do laparoscopic cholecystectomies in this small hospital where they don't do it usually, but 15 minutes away, they do it. And we talked to the surgeon up at the other hospital, and he said, yeah, we have a problem with that group. Why is that? Because the people now don't trust us, and they wait for this group to come and do it on a yearly basis. And we have some of that. When we come back and work, people would show up with the more difficult problems. But we made it a real effort to say, we're here to help your surgeons. Your surgeons are good. Look what they can do. And so even in our communication, we tout about the improvement in their surgical care. One of the biggest questions I had on the news, how are our surgeons? Are they safe? And so how do you respond when, yes, they are safe and they're improving and they're making progress, but they may not be quite like Dr. Latifi. But you want to be honest, but you want to support them and build them in their work. In terms of sustainability, I really learned that in Mongolia too. We are working with this foundation and with many people who are donating things. And you have to understand what regulations are and building the business community. How do you build the support for laparoscopy if you're bringing in everything? Where's the business going to come from? You're going to be competing with people you set it up with. The colorectal surgeons came to me and said, Ray, my plan was initially bring enough trocars so they had enough to do it till we came the next year, so they could practice or do the surgeries. He came and said, Ray, you're bringing in so many trocars, you're shutting down the ability for us to develop the business to support it. Big failure on my part. So we backed off and we brought it into our warehouse and began to sell it at a low cost. And then we set up some of the doctors as distributors. And then we shut off the volunteer component. So you guys are gonna have to figure out how you're gonna support this. Because it can't be based on just a volunteerism donation kind of thing. So.
Okay, any other comments? Well, thank you very much, Dr. Price. This was a real treat for us. Thank you. Thank you.
Okay, now it will start with the second session of the podium presentations. And the first speaker is Faisal Jihan. It's on? All right, hopefully people can hear me. Thank you. Faisal Jihan will be our first speaker of the afternoon's podium presentations. The title of his talk is Fresh Frozen Plasma and Platelets is Associated with Better Outcomes, even in trauma patients requiring submassive transfusion. Dr. Jihan.
Hello, good afternoon, everyone. First of all, I would like to thank the program committee for giving us the opportunity to present our work. The topic is administration of fresh frozen plasma and platelets associated with better outcomes, even in patients requiring submassive transfusion. I have no financial disclosures related to this topic. Just going into the background, damage control resuscitation was early on defined as administration of blood products for the trauma patients who were bleeding and who were hypertensive in the field. The optimal trauma resuscitation fluid, which used to be crystalloid at some point in time, have now been replaced with blood and blood products, including packed red blood cells, plasma, and then platelets, which are the actual components of blood which you're losing in the actual trauma. There are the massive transfusion has been traditionally defined as patients who require more than 10 units of packed red blood cells in the first initial 24 hours after trauma. However, most of the trauma research we see is dedicated towards patients who require massive transfusion. And it is in this subgroup of patients that all the guidelines, including what products should be given, at what ratio should be given, is all evaluated. But it is noteworthy to mention that massive transfusion occurs in only about 3% of the civilian trauma and about 8% of the military trauma. So in the United States, we only deal mostly with the civilian trauma, which is only 3%. The rest 97% do not require any massive transfusion. If any, they would require a submassive transfusion, which would be defined as receiving less than 10 units in the first 24 hours. As previously mentioned, multiple studies, including the bigger, the PROM trial, which looked at the ratios of plasma, platelets, and PRBCs, as well as the pragmatic randomized optimal plasma, platelet, and RBC ratio, evaluated that transfusion of these products in a 1:1:1 ratio is associated with improved outcomes. However, as said earlier, all of these patients were severely injured, requiring more than 10 units PRBC transfusion in the first 24 hours. However, only 3% of that trauma is massive transfusion. So our interest arises in what about the 97% subgroup of the patient? They only received submassive transfusion. Does FFP and platelets in these trauma patients affect any of those outcomes? Taking this question on, the aim of our study was, does administration of FFP and platelets along with PRBC in trauma patients requiring submassive transfusion affect outcomes? We made the hypothesis that FFP and platelets along with PRBC in trauma patients would lead to an improved survival. We defined submassive transfusion as patients receiving less than 10 units of PRBC in the first 24 hours. For this purpose, we used the American College of Surgeons Trauma Quality Improvement Program database, which is a robust system that is contributed by all the level 1, level 2, and the level 3 trauma center in the United States. Our inclusion criteria were all adult patients, age 18 or greater, who received at least one PRBC in the past 24 hours, submassive transfusion, meaning that 1 to 9 units in the first 24 hours. Patients who received more than 24 hours were not included. On the other hand, patients who were transferred from the other hospital as well as those died within the first 24 hours were excluded. We further stratified our patients based on our regression analysis into two groups, those who received more than 3 PRBCs alone and those who received more than 3 RBCs with at least 1 unit of FFP, or a platelet. Our primary outcome was mortality, and our secondary outcome were overall complications, and then further subdivided into acute kidney injuries, acute respiratory distress syndromes, sepsis, and then thromboembolic complications. We use multivariate regression analysis as well as propensity score matching to evaluate our outcomes. This is the demographics of our overall subgroup. The mean age was 53. Most of them was male, and most of them had blunt injuries, 84%. Only 8% had TBI, while the most common injuries were either extremity or abdominal AIS. The mean injury severity score was 11. The vital parameters were systolic blood pressure of 87, and then heart rate of 101, and then the mean GCS was 13. We had a total of 85,000 patients who received submassive transfusion. We performed a regression analysis controlling for age, gender, race, injury severity score, body region AIS, emergency department vitals and GCS scores, temperature, and the anticoagulant use, and then compared our PRBC alone group with PRBC group who received at least 1 unit of FFP or platelet. We named it as the combined resuscitation group. This graph demonstrates that the PRBC alone group for each unit was taken as a reference. As you can see, there was no significant difference in those patients who received 1 unit of PRBC and those who received 1 PRBC with a platelet or FFP. Similarly, no difference because it crosses the odds ratio of 1. No difference in those who received 3 units of PRBC alone or with or without FFP or platelet. However, we notice a change that as patients received more than 3 units of packed red blood cells, those who received at least 1 FFP and platelet with them, their mortality was 20% lower, and that persisted in those who received 5, 6, and 7 units of packed red blood cells, and that was all statistically significant. However, those patients, the group were too smaller in patients who received 8 or 9 PRBCs because almost all of those patients received at least 1 FFP or platelet. That's why this could not reach statistical significance. From our previous graph, we obtained that patients with more than 3 units of packed red blood cells with FFP and platelet had better survival. Then we further made 2 groups of those patients into those who received PRBC alone and those who received combined resuscitation, and then perform propensity score matching for their age, gender, race, ED vitals, and anticoagulant use to look for if they have any difference in their outcomes. About 8,000 patients were matched in the 2 groups. 4,000 we did perform matching in 1-to-1 ratio. So we had 4,215 patients in both groups. This is the demographics of our match group. As seen, there is no difference in the age, gender, the mechanism of injury, the injuries, and the ISS, which means that our propensity score matching had worked. There was no difference in the ED vitals as well, so that we are comparing 2 equal groups of patients with same injury presentation as well as ED vitals. This is the slide that compares our secondary outcomes, which are complication. The complication risk was higher in those who received just PRBC alone compared with the combined resuscitation in those who received 3 or more PRBCs. The rates were significantly higher in ARDS and acute kidney injuries, which was 5% and 3%, and then 11% and 8%. However, there was no difference in the septic complications as well as the venous thromboembolic complications between the 2 groups. In the light of our study, we concluded that trauma patients requiring more than 3 units of PRBC who receive either an unit of FFP or platelets have improved survival compared to their counterparts who only received PRBC transfusion without any other adjuncts. Patients with combined resuscitation also had improved overall outcomes. The most common noted were acute kidney injuries as well as the ARDS. Further studies are required to evaluate the optimal ratio of the blood products in patients requiring submassive transfusion. I'll be happy to take any questions. Thank you for the opportunity again.
David, I noticed that you had to trim a lot of the index group, the PRBC only group, to get matching on the propensity scores. What approach did you use to trim? I mean, did you just exclude a lot of the very high propensity scores? How did you go about that?
So I did like propensity score matching on the most closer variables. So those patients who had a match in the other group were matched for the first one, because our patients who received the PRBC only had a higher number. That's why a lot of those patients were excluded, because we only got a match to those who had the combined resuscitation and injury parameters similar to those ones.
Okay, thank you.
Other comments or questions from the audience? Want to introduce?
Okay. I'm taking over for Dr. Prabhakaran. He's got to excuse himself early. It's my great privilege to be here to announce the rest of the podium presentations, as well as the posters that'll come soon afterward. We are next going to hear from Jack Tesoriori and Jake Schwartz. They're going to talk about radiographic analysis of prosthetic implant position in robotic assisted and manual hip and knee arthroplasty.
Yeah, that works.
Hello, everybody. I'm Jake Schwartz, and this is Jack Tesserero. We are third-year medical students, and we're going to be discussing our project on the radiographic analysis of prosthetic implant position in robotic-assisted and manual hip and knee arthroplasty. So just to start off with some background, osteoarthritis is a leading cause of injury and disability in the United States, and rates are increasing, likely due to the increase in the aging population and the increases in average BMI in the United States. There are several treatments for osteoarthritis, including physical therapy, several different types of injections, and arthroplasty, which is indicated for end-stage osteoarthritis. There are several factors which influence the outcome of these procedures, including the patient's BMI, their age, and also the alignment of the implants which are placed, which is a surgeon-dependent outcome. And this is something that can be targeted, being surgeon-dependent, and can lead to better outcomes for patients. Outliers in implant alignment are associated with increased wear, impingement, dislocation, and need for revision in patients. So because of the need for this accurate implant alignment, robotic systems have been designed to allow very precise cuts in bone and implant of the prosthetics in both hip and knee arthroplasty. So previous research has shown that use of these robotics decreases the amount of outlier implants, but it is unclear, however, if this is true for both high and low volume surgeons. Most of the research to this point is done by high volume surgeons at high volume centers for arthroplasty. So because of this, we wanted to look a little bit closer at the implant alignment and the number of outliers in hip and knee arthroplasty in high and low volume surgeons, and compare these for robotic assisted and manual hip and knee arthroplasty. So we did this by collecting data of 850 hip and knee cases. 500 of them were robotic cases using the Mako robotic arm, and 350 of them were manual cases. These were split about 50-50 between hip and knee. We collected data including patient demographics, operative time, length of stay, percentage drop in hemoglobin from pre-op to post-op as a marker of blood loss, complications, and we measured implant alignment as our primary outcome. So we stratified the surgeons that were doing these procedures into low and high volume based on the number of cases they performed. Over 50 cases per year was considered high volume, and under 50 cases a year was considered low volume. So just to quickly go over what these angles are, for hip arthroplasty, we used abduction angle, which is the angle between the plane between the angle of the plane of the most inferior portion of the ischium and the major axis of the acetabular cup. And 30 to 50 is considered accurate and is associated with better outcomes. And for the knee, we measured both degree of varus and valgus and the posterior slope. These are measured by the angle between the tibial plateau and the midshaft of the tibia. For the degree of varus, this is doing this on an AP radiograph, and for the posterior slope, this is done on a lateral radiograph. And the degrees we use for this are -3 to 3 for varus valgus and 0 to 7, and these are associated with better outcomes.
So here for the results, on the left, we have the hips, and on the right, we're following the knees. We looked at 3 things here: the length of stay in days, the percent hemoglobin drop, and then finally the operative time in minutes. So for the length of stay and the percent hemoglobin drop, it was pretty comparable, but high volume Mako did have the best results in the shortest amount of stay and also in the percent hemoglobin drop for both hip and knee. Where I did want to focus was the operative time, because one of the big drawbacks of robotics in general is that they take longer. But when we look at the high volume Mako and the high volume manual, they were actually almost identical in terms of length. So after the surgeons master this technique, they are able to get the robotic surgeries almost identical to the manual ones. And that was true of, it was pretty close in both low volume as well. But for the knee surgeries, the Mako did take a significantly longer time, whereas the manual was about 69 minutes, the Mako is about 90. And that was also true for the low volume, where it was about 20 minutes longer. And I'll talk a little bit about why that could lead to more complications. So this was the primary focus of our study, where we looked at the radiographic outliers. And for the Mako in blue, as we could see, there was a much smaller percentage of outliers present. And what was interesting was no matter high or low volume, they were able to maintain that improved radiographic findings post-op. So this was looking at abduction angle for hips. And then here we're looking at the posterior tibial slope on the left and the degree of varus valgus. And these are both for the knee arthroplasties. So once again, we could see that the Mako surgeries led to a much smaller percentage of those outliers being present. Just to note here, the low volume surgeons didn't report, we didn't measure any outliers, but that could also be just due to the smaller sample size there. So I kind of touched on these things before, but the length of stay was shorter in the high volume Mako, hip or knee. The percent hemoglobin drop was the shortest in high volume Mako knee. And the operative time was longer in the robot assisted knee surgery, and longer operative time means the patient's going to be under anesthesia for a longer period, and the tissue is exposed for a longer period of time, placing it at a higher risk for infection. So that is the biggest drawback of robotic assisted surgeries in general. And then just the focus that we talked about before, regardless of high or low volume, there were better radiographic results with fewer outliers present, meaning that the prosthetic had a tighter, more balanced fit. And what this means, previous studies have shown prognostically that an abduction angle within that acceptable range leads to less risk of wear, edge loading, impingement, or dislocation. For the knee surgeries, having the posterior tibial slope within that range has an improved range of flexion, improved tension in the knee ligaments, and less risk for subluxation or dislocation. And okay. And just to conclude here, regardless of high or low volume, the robot did lead to better radiographic results. So we just state that this shows that robots have a place in orthopedic surgery in the future, and we're hoping more surgeons adopt this technique. And these are just our limitations, but I think we're ready for questions now. Thank you.
Thank you. Comments and questions for our presenters? Okay, thank you so much.
Thank you.
Oh, wait, I'm sorry.
I would say for joints. Yes, we're trying.
Hopefully.
I would say for joints, it's looking like that. So
There are other factors that we need to consider as well, like the cost and the training of these, but I think that it could be heading in a direction where more and more centers are adopting the use of this technology.
Because the other hospital down the street can have one. And I promise you, the patient will say, I want to go to the doctor without this robot. So we get it before, just like we were initially when we started buying these robots, it was really more marketing than anything else. At least that was my opinion. And now I don't think it's marketing. I think it's good. But I think we're going to be pushed to buy robots. I told my boss the other day in the corridor that in 5 to 10 years, it may be less than that. But I don't think it's more than every operating room probably will have a robot. In major hospitals, even in small hospitals.
Thank you very much.
Thank you. Our next two presentations are going to be recorded. So the technician will help get those up. The first is by Madison Kassoff. That presentation is level of fear in adult patients undergoing elective urogynecology or gynecologic surgery during the coronavirus disease 2019 pandemic. Should be 2020, using a validated surgical fear questionnaire.
Hi, my name is Madison Kassoff, and I'm a rising third-year medical student here at New York Medical College. And today I'll be presenting a study entitled Level of Fear in Adult Patients Undergoing Elective Urogynecologic or Gynecologic Surgery During the COVID-19 Pandemic using a validated surgical fear questionnaire. And we have nothing to disclose today. So as you all know, New York State underwent lockdown back in March 2020 and halted all elective surgeries to best control the spread of the coronavirus. As the New York hospitals began to experience lower COVID-related patient volume, elective surgeries resumed. And this provides a unique framework through which to assess patient fears regarding surgery in light of these recent global health conditions. And review of current literature shows that perioperative anxiety is common amongst patients undergoing surgery and has been shown to correlate with postoperative mood and pain. Recognition and understanding of patient fears allows the healthcare provider to better care for patients undergoing surgeries or procedures. So the primary objective of our study is to assess fears surrounding elective surgeries and office procedures in a benign gynecologic and urogynecologic population in the context of the COVID pandemic. Our secondary objective is to trend these average level of fears as the COVID pandemic continued, but the lockdown was lifted. We hypothesize that the COVID-19 related fear is significant and would show a correlation with the course of the pandemic. So this is a multi-center prospective observational study conducted at Lenox Hill Hospital, North Shore University Hospital, Long Island Jewish Medical Center, and here at Westchester Medical Center. Recruitment occurred from June 23, 2020 through March 23, 2021. And females 18 years or older presenting for benign elective urogynecologic or gynecologic surgery or office procedures were eligible to participate. Patients were excluded if they were non-English speaking, unable to consent, or undergoing a procedure or surgery for malignant pathology. Fear was assessed using the surgical fear questionnaire, which I'll refer to moving on as the SFQ. And this is a validated 8-item survey, which evaluates short-term and long-term fears related to surgery. And in this study, we added additional instructions to SFQ to place the questions in the context of the COVID pandemic. Our modified version of the SFQ, known as the MSFQ, includes questions that were pertinent to the pandemic. Questions were scored on a scale of 0 to 10, with 0 being not at all afraid and 10 being very afraid. And patients received either the 10-item procedural MSFQ or the 14-item surgical MSFQ with a maximum of 100 points and 140 points respectively. Here are the questions which we used in the procedural and surgical MSFQs, and a subsection of the questions focused on fear of the short-term consequences of surgery, such as anesthesia and unpleasant side effects, and another group of questions focused on fear on the long-term consequences, such as recovery and long-term health outlook. Finally, there were COVID-specific questions, such as concern for family, risk of infection in the hospital, and status of hospital staff and doctors. And now we'll take a look at the results of the study. So a total of 209 surveys were completed from our patient population. The average age of patients was 54.68 years old, and most respondents were white, followed by Black or African American. Almost half of our patients had private insurance, with 35% of patients having completed an undergraduate degree and 25% having had an advanced degree. The prevalence of chronic pain, depression, or anxiety levels was similar to national statistics, and 80% of our patients had had a prior surgical history. Overall, only 17% of our patients experienced a delay in care due to the COVID pandemic. So out of our 209 surveys completed, 107 were from patients undergoing office-based procedures, and 102 were patients undergoing elective surgery. The different types of procedures and surgeries are outlined here, and the most common office procedure were urodynamics, and the most common elective surgery was hysterectomy. The overall average SFQ score out of 80 was 12.38 for procedures and 12.03 for surgeries. And when the additional questions specific to COVID-19 were added, scores were 20.57 out of 100 for procedures and 28.78 out of 140 per surgeries. The mean scores per question did not differ significantly between our surgical and procedural groups, and the highest scoring questions overall were about hospital admission and family concern. Here you can see that we trended the average SFQ scores over time for surgical and procedural groups, and we highlighted various time points across the 9 months, including various phases of lockdown, reopening in New York, and other COVID-related time points. There is no significant fluctuation in average SFQ score over time or in relation to the COVID-19 events. And the initial peak you may see in SFQ scores around phase 1 and 2 is limited by a small sample size for those time points, as surgical cases at the time were still limited. Due to the extraordinary circumstances of being in a pandemic, we hypothesized there'd be a significant amount of fear in patients undergoing procedures and surgeries, and the present study found no significant level of fear reported in our patient population. Previous studies report an average SFQ score for benign elective hysterectomy to be in a range of 13 to 22.9, and unexpectedly, the average level of fear in patients undergoing hysterectomy during the pandemic was lower than in previously published data, with our study finding a mean SFQ score to be 12.49. The greatest levels of fear were about admission to hospital following surgery or procedure, and about concern for family during the pandemic, as I mentioned before. And there were no significant correlations seen between fear scores and major COVID-19 events. The main strength of this study is its design as a prospective multi-center study of a large, diverse population around the New York metropolis area. And as you know, this area was an epicenter at the onset of the pandemic. And we present the first prospective study investigating fear specifically related to COVID-19 and non-emergent gynecologic care. As with any survey study, there are limitations such as selection bias, and our cohort comprised of only female patients who already decided to seek medical care, so results may underestimate population COVID-related fears. Additionally, by excluding non-English speaking populations, we may have underrepresented groups who were disproportionately affected by the pandemic and lockdown. As I've discussed with you, the level of fear towards surgery and office procedures is found to be low and consistent throughout this documented period of the COVID pandemic. And this level of fear was lower than historical averages and did not fluctuate over time, though fear scores did increase with the inclusion of COVID-specific questions. And I just want to take a moment to thank my entire team, both here at WMC and NYMC, as well as Northwell Health for all the hard work we've put in this project over the past year. And I'm sorry I wasn't able to be there in person today, but thank you all for joining me for my presentation. Please don't hesitate to reach out with any questions or comments. Listed here is my email and Dr. Grimes' email. And thank you for listening to my presentation today.
So next up will be Lior Levy. Her topic is regeneration of bones in non-union defects in rat femurs using multipotent adult stem cells.
Hi everyone, my name is Lior Levy, and this past summer I had the privilege of working with Dr. Paul Lucas in the Department of Orthopedic Surgery. And today I'm going to be presenting to you a project called Regeneration of Bone in Non-Union Defects in Rat Femurs using Multipotent Adult Stem Cells, or MASCs. We have nothing to disclose, and non-unions represent a continuing medical problem. Adult stem cells are one possible treatment, and MASCs are unique, easily isolated, and have apparently unique proliferation potential. And so we isolated MASCs from skeletal muscle tissue, and these cells have unlimited mitotic ability and can give rise to multiple phenotypes in vitro. And this includes skeletal tissue types such as cartilage, skeletal muscle, bone, and connective tissue. So these MASCs in polyglycolic acid felt scaffold, or PGA, have previously been shown to regenerate bone in a critical size rat called variole defect. So here are our methods, and just in short, what we did is we thawed and cultured these MASCs on a polyglycolic acid felt scaffold for about 3 weeks. We then created our 3 experimental groups. So the first one is when we had the femur defect and that was left empty. The second one is when we had the rat femur defect with our polyglycolic acid felt scaffold as is. And the third one is when we had the polyglycolic acid felt scaffold with our multipotent adult stem cells. So we created an 8 to 10 millimeter defect in the rat femur, as you can see here. And then they were left to sit for about 8 weeks. And then they were photographed and processed for histology and scored by our blinded scores. So here are some of our results. So first of all, we have slide A, and in slide A, you have our first experimental group, and that is when we had the empty rat femur defect, so no scaffold and no stem cells. And as you can see in the circle, there was no regeneration of bone, as you could probably expect. And now if you turn your attention to B, this is our second experimental group, and we had the rat femur defect with the polyglycolic acid scaffold alone, so no stem cells. And as you can see here in the middle, in the circle, we had some loose connective tissue, but no bone reformation. If you turn your attention to C and D, this is our third experimental group where we had the PGA scaffold with our multipotent adult stem cells. And I'm outlining the defect with my cursor, which you could probably see the outlines. So after 8 weeks, you can see on gross examination that we do have bone reformation. And you can see the same thing with slide D. So that's great news. Now we did the exact same thing, but we did this on histology. So first turn your attention to slide A. Slide A is, as you can see by the arrows, is pointing to the borders of the defect. And again, we had an empty defect, so no scaffold and no stem cells. And you can see here in the middle that there was no bone formation in the middle, and it was still left as a defect after 8 weeks, as you could probably expect. And if we turn your attention to B, again, I'm highlighting the borders of the defect with my cursor, and this is just where we had the PGA scaffold. And you can see here marked with an asterisk that we had a little bit of loose connective tissue formed, however, no bone reformation was present. And now finally in C, this is where we had our scaffold with the stem cells. You can see, as outlined by the arrows, this is where our defect was originally. However, as you can see, after 8 weeks, we had bone formation, due to the effect of the stem cells. And here are here's the exact same images, but on higher power. So A is where we had an empty defect, and we have a little bit of connective tissue, but again, no bone formation. In slide B, you have here again the bone, which is from the defect, but again, just some loose connective tissue after about 8 weeks. And in C, here you can see this is where we had the scaffold with our multipotent adult stem cells. And you can see, as shown by the arrows, you have a bit of bone reformation and a little bit of osteoid. So that's great that you can see it on gross and on high power microscopy. So in terms of our limitations, we had a small number of animals. So we used about 17 rats and their femurs. So maybe we would be able to have more animals in the future. We also had a short-term follow-up. So we had about 8 weeks. So even though we had really great results in a very short-term follow-up, you know, in terms of patient outcomes, we want to make sure that we are following the progress for a much longer period of time. We had no radiographic evaluation, and we also had no biomechanic analyses. So we didn't test for any strength or torsional rigidity, which could also, again, be very important when assessing patient outcomes. So our conclusion is that undifferentiated multipotent adult stem cells, which were embedded into the PGA scaffold, were able to achieve bone regeneration and union 8 weeks post-operation. And this was all done in vivo. So thank you everyone for listening. And my name is Leora again. And if you have any questions, you can feel free to email me. It was a pleasure to be part of the conference. And thank you so much for listening.
All right, we're going to move on to the poster presentations. And I want to just let you know that there will be a brief PowerPoint presentation for each of the speakers. And at the end of that, you'll see the actual poster as well. These presentations and the Q&As will be limited to 5 minutes. So we're going to have to keep up a good pace. So the first speaker is Ansab Haider, who's going to talk about the effect of individual surgeon volume on outcomes after aortic aneurysm repair. Is there a minimum threshold? Okay, so skipping over Ansab, we'll be moving on to Matt McGurk, who's going to discuss independent predictors for surgical site infection in patients undergoing complex abdominal wall reconstruction.
Poster. Ready? Hey, good afternoon, everyone. I'm here to present the third one. So this one's independent predictors for surgical site infections in patients undergoing complex abdominal wall reconstruction. Some of this will be similar to my first presentation this morning. This was the first project, and the one that I presented this morning kind of built off of that. So some of the themes will be similar. So complex abdominal wall reconstruction is a large surgical problem that's becoming more and more prevalent nowadays as patients are having more surgeries, more complex surgeries, leading to more hernias, larger hernias, bigger defects. Complex abdominal wall reconstruction has been shown before, both through research out of our group and out of others, to be associated with different wound complications such as SSIs, reoperation, and the need for mesh explantation. SSIs are correlated then further along with increased need for readmission, prolonged hospital length of stay, and increased reoperation risks. So we are looking to identify different independent risk factors for SSI following complex abdominal wall reconstruction. This is actually the picture that I had promised earlier, the inside view of the fistula. So this is a patient that had almost a huge mushroom cloud of small bowel that was adherent to a synthetic mesh, leading to this fistula you can see in the top picture. So this was also an ambidirectional cohort study of all patients undergoing complex abdominal wall reconstruction here. And the one definition we had is that prior abdominal infections were defined as all history in every patient's chart of any prior superficial SSI, deep SSI, organ space infection, enterocutaneous fistula, or multiple areas that were infected. So we're grouping all those together to mean prior abdominal infections, no matter where along their timeline they've had them, just as long as there was one before our surgery. So, for example, that would qualify as a primary abdominal infection. So we then grouped patients into those who developed an SSI postoperatively from our procedure and those who did not, and compared any differences between the two groups. We ran a GAM model to show whether or not we could include age, length of stay, and BMI as a continuous variable, whether or not they had a linear relationship with SSI postoperatively, and they did have a perfectly linear relationship, so we were able to include them just as a continuous variable, and then created a regression model to look at risks for SSI following our procedure. So this was 240 patients with a SSI rate of 16.3%. Of the patients that we had in our group, 40% of them had had a prior infection coming into our procedure. We then looked at those that had the prior infections and saw that they had significantly more SSIs postoperatively from our procedure. They also had a longer operating time, longer length of stay. They had increased stoma takedown, intestinal resection, paniculectomy. So then we ran two different regression models. One was with length of stay, one was without. We were trying to see whether or not it was a cause or an effect, really. And we kind of found that it was both. So if we look at it without SSI, or without, sorry, length of stay, we see that prior abdominal infections and BMI were the two that were found to be significant risks for developing an SSIs postoperatively, with the prior abdominal infection making a patient have an increased odds about 2.5 times, whereas BMI, for each increased unit of BMI, patients had a 5% increased risk of an abdominal SSI postoperatively. Then looking at including the length of stay, we see that length of stay also ends up being a significant risk, with each additional length of stay placing patients at a 4% increased risk of an SSI. So in conclusion, we found that the presence of prior abdominal infection, increasing BMI, were both independent predictors of SSI following an abdominal wall reconstruction. Additionally, it appears that hospital length of stay is also increased, is also an additional risk for an SSI. Here's the poster. Any questions? Saying, so what are their risks? So I would say that any patient that after doing the history with them, if they have a history of diverticulitis, history of prior SSI, history of any of the things we've studied, just to let them know that we have to keep a closer eye on them postoperatively. They're at an increased risk, depending on what type of abdominal infection they had before. So for example, if they had a history of diverticulitis, let them know that there's an increased risk that postoperatively they'll need another surgery, maybe need to be readmitted. And that's why we're going to have to keep a close eye on them afterwards. Yeah, of those that had a prior infection, 56% developed a new one. It's over half, yeah. Yeah. I think the main thing is just as long as you give them a good talk before and let them know the expectations, and they at least know going in that that's the risk, so that they're at least informed going in that they've got a high probability that could happen. So they most kind of, that ties into my first presentation, that they're most likely gonna, they have risk of reoperation, readmission. They're Mm.
We struggled with that. It's very difficult because they tell you that I cannot walk, I cannot move. And one patient I postponed for a couple of months. Eventually they have an emergency surgery. So I encourage them, but I have to stop mandating because it just doesn't go ahead and get you anywhere.
I think there's
I really have a problem with number 12. I try to even in those so that I go to that early. That's a problem. I use that song. No, I use that. Oh, you use that. I use that. You said it. Song in here. Why? Because I think I'm getting ready to open it. Anything larger than what's pretty much used.
Thank you, Matt. Our next presenter will be Tantan Nguyen, who will talk about crossovers with intention to treat analysis in surgical randomized trials.
Hello. How do I click next? Hi, my name is Tan. I'm a first-year surgical resident, and today I'm presenting the study crossover with intention to treat analysis in surgical randomized controlled trials. And I have nothing to disclose. A little bit of background. So randomized control trial is the most effective way of establishing a causal relationship between an intervention and an outcome, because it allows for an unbiased comparison between the two groups, and it allows for control of both the known and unknown confounding variables. However, sometimes during a study, patients does not end up undergoing the treatment that they were assigned to, and this is called crossing over. And intention to treat principle counts these crossover as the original assigned groups instead of the actual treatment that these patients received. So for the objective of the study, we want to assess whether or not crossover with the intention to treat analysis may bias the reporting of a randomized control trial. So for the methods, we looked at several randomized control trial that uses intention to treat analysis to and analyze these crossover patients. And a meta regression was performed to assess whether these crossover rates has any correlation with the specific endpoints that was looked at in these studies. And specifically for this study, we looked at 4 studies in several European countries looking at patients undergoing, patients with Hinchey class 3 and 4, and who was referred to a tertiary center, who ended up going either a primary anastomosis or a Hartmann procedure. And the relevant clinical endpoint that we chose to look at was a ostomy non-reversal rate. So in these studies, when a patient was randomized to, let's say, primary anastomosis, but for some reason the patient ended up getting a Hartmann procedure. However, during the end of the study, the patient is still analyzed as a primary anastomosis patient, the patient who undergoing primary anastomosis. So when there is favorable outcome, it might falsely favor primary anastomosis. However, if there is unfavorable outcome, then primary anastomosis will look like it will have more adverse outcome. So for result, we out of these 4 randomized control studies, we saw there was 4% crossing over from primary anastomosis to a Hartmann procedure, but there was only 1% of patients going from Hartmann procedure who were assigned to a Hartmann procedure who ended up going primary anastomosis. And so when we looked at the 4 studies combined, it looks like those that underwent primary anastomosis, only 16% of these patients ended up having there was 16% with non-reversal rate versus 35% in the Hartmann procedure, which statistically favoring the primary anastomosis procedure, which is not usually what we see. However, when we compare the crossing over rate and the ostomy non-reversal rate, it looks like the studies with higher crossover rate from primary anastomosis to Hartmann procedure, the study shows a lower rate of ostomy non-reversals. So for a conclusion, it looks like the meta-regression found that crossing over with intention to treat analysis did significantly bias the result of these randomized control trial in favor of primary anastomosis.
When you have crossover, you're going to have possible confounding because if you analyze it as per protocol, the groups may not necessarily be balanced anymore.
Yes.
So what is your alternative to doing just a crude analysis of the outcome? What else?
That I'm not quite sure, but like you said, when the patients, if these patients are analyzed as per protocol, you are introducing selection bias to these studies. So it's not purely a randomized control trial anymore. So I think it's more that readers should be more aware of the intention to treat analysis doesn't actually means that it is pure randomized, but then there is bias to it.
Can we see your poster? Thank you. Okay, our next presenter will be Mohammed Zishan. He will discuss balanced damage control resuscitation is associated with improved outcomes in severely injured pediatric trauma patients.
Good afternoon, everybody. I'm Mohammed Zishan. I'm one of the second-year resident in general surgery. I'll be presenting my paper on balanced damage control resuscitation in pediatric trauma patients. I have nothing to disclose. Trauma is the leading cause of death and disability in pediatric trauma population, and post-traumatic hemorrhage is the most common preventable cause of death in these patients. Multiple studies, especially in the adult world, has shown that a balanced resuscitation with 1:1:1 ratio of blood products is associated with improved mortality. There have been a couple of studies in pediatric trauma which shows that a balanced resuscitation is associated with improved outcomes. However, these studies are smaller studies in one or two centers, and there is paucity of data regarding the resuscitation in pediatric trauma patients in national level. So the aim of our study was to assess the impact of near balanced resuscitation on outcomes in severely injured pediatric trauma patients receiving massive transfusion using a national database. So we performed a 3-year analysis of the pediatric ACS T-Cube database, and we included all the PEDS trauma patients who received massive transfusion, which was defined as transfusion of PRBCs of 20 cc's per kilo within the 24 hours of arrival. The outcome measures were in-hospital complications, 24-hour mortality, and in-hospital mortality. Based on the ratios of blood products, we divided our patient population into 2 groups. A near balanced resuscitation included the patients who received PRBCs to platelet to FFP in a ratio of 1 cc's to 0.5 or greater than 0.5 cc's of platelets or FFP during the first 4 hours of resuscitation. We included a total of 536 pediatric trauma patients who received massive transfusion. Out of that, only 26% of the patients received a near balanced resuscitation. This table represents the univariate analysis of our outcomes. On comparison, the patients who had near balanced resuscitation had lower in-hospital complications, most significantly lower rates of AKI and ARDS. On analysis of the 24-hour and in-hospital mortality, our results showed that the patients who had a near balanced resuscitation had a lower mortality as well. Then we performed a multivariate regression analysis to control for confounding variables, including injury parameters, the amount of blood products received within the first 24 hours. And we found that on regression analysis, while controlling for confounding variables, a near balanced resuscitation was associated with lower odds of complications, 24-hour mortality, and lower in-hospital mortality. In the light of our study, we conclude that only 1 in every 4 severely injured post-trauma patients receive a massive transfusion in a near balanced resuscitation manner. In the post-trauma patient, a near balanced resuscitation is associated with lower mortality and lower complications compared to an unbalanced resuscitation. And I would be happy to take your questions.
Any questions? Thank you, Mohammed. Our next speaker will be joining us virtually. He's Radu Filipescu. His talk is Random Forest Model using International Classification of Disease Injury Codes, or ICD-10, clinical modification, outperform injury severity score in predicting outcome and hospital length of stay.
Hi, my name is Radu Filipescu, and I will try to explain the poster I submitted dealing with random forest as a better anatomical injury severity characterization. This work is dedicated to Dr. Tipas, who has been an inspiration to the authors. Injury severity score using abbreviated injury scale is the uncontested until now standard in anatomical injury characterization. It has been around for almost 50 years. It is owned and maintained by the Association for Advancement of Automotive Medicine. Their methodology is proprietary and hence not widely available. AIS consists of a pre-dot section, which describes the anatomical location and the structure afflicted by the injury, and the post-dot portion, which defines the severity, which can take values from 1 to 6, 6 being unsurvivable. Pictured is the code for a femoral shaft fracture. ISS is the sum of the squares of the severities of top 3 most severe injuries from different body regions, regardless of the total number of injuries. It can take values from 0 to 75. There are several variations to this method described. New ISS uses top 3 most severe injuries regardless of the body region, and weighted ISS, which uses top 3 most severe injuries in different body regions. However, it uses weights specific for each body region. There is plenty of criticism, and from simple to complex, it requires translation. ICD-10 codes must be translated into AIS codes. This is generally done by medical coders which lack medical expertise. This is accountable for an error rate of approximately 20%. It has a flawed methodology. Why only 3 body regions? Why not 2 or 4 or all of them? There is no evidence to support 3 is the magic number. Why 1 to 6 severity scale? While with regards to internal organs, it makes anatomical sense. How about the other anatomical structures? According to numbers offered by the company, the mortality for severe and critical is the same, 50%. It does not account for age. It overestimates mortality in children with ISS scores less than 25. It does not account for injury combination. One of the most famous idiosyncrasies of ISS is different mortalities per ISS value. For example, an ISS of 25 can be due to a single injury with severity of 5, in which case mortality is around 35%, or it can be due to 2 injuries, one of severity of 4 and a second with a severity of 3. In this case, mortality is around 20%. Random forest is the best classification method for large data sets with very diverse categorical data. ICD-10 codes, about 15,000, are exactly that, categorical and unique. What you see to the left is a decision tree. Every node on it represents a unique combination of injuries in this case. The model compares the outcome for every node on all the trees and reports it as multiples of the baseline mortality encountered in the cohort. We hypothesized that such a method would increase the outcome prediction accuracy, but because the analysis requires extraordinary computing power, we decided to run first a proof of concept to demonstrate that random forests using severity of the injuries mapped to 9 body regions would outperform ISS. And if this was the case, to go for the holy grail, ICD-10. Ideally, such a model would analyze all 15,000 diagnostic codes, including the ICD-10 book, that describe the clinical state of a patient, including both acute traumatic diagnosis and diagnosis of pre-existing conditions. For the first parts of the study, we used severity post-dot matched by body region, pre-dot. We included 2.5 million patients, and we trained and validated the model both in pediatric and adult trauma populations. Because of the lower number of pediatric patients, we used different training samples, 30% for children, 3% for adults. The models were trained on the training sample and validated on the testing sample. In other words, the trained accuracy was put to test on a totally different sample. When we used ICD-10 codes for overall comparison, we used only the root of the diagnosis found in chapter 19. This implied analyzing combinations of over 1,500 roots. For example, SO6 intracranial injury is a root encompassing all the individual D codes like subdural, epidural, subarachnoid, intraparenchymal hemorrhage, and so on. To compare injury combination outcome prediction, we used 1.8 million patients, 10% pediatric, mortality 2.5%. We tried to narrow the number of variables, hence we selected patients with isolated head, isolated thoracic, and isolated abdominal injuries, and with one-to-one combinations of the three. The random forest AIS model outperformed ISS in both children and adults. The model is training dependent, bigger sample, better the accuracy. Please note on the merged cohort, the accuracy in children was higher due to training on adults. Age turned out to be quite important in predicting outcome, and the model integrates it by design. Head, thoracic, and abdominal injuries were most lethal when compared to other body regions. ICD-10 random forest using the decode root and no severity performed on par with random forest AIS. This cast doubt on the real utility of the extensive coding used by AIS. In survivors, on the other hand, random forest using decodes was clearly superior in predicting the length of stay. Looking at the injury combination from the AIS perspective, here on the left we have isolated head injury. We can clearly see a head injury with AIS of 4 has 1.2 times higher mortality than cohort's baseline, which, to remind you, is 2.5%. On the right, we have an isolated thoracic injury, which for a severity of 3 bears a mortality 1.1 times cohort's baseline mortality. In the center, we have the mortality of the combination of the two, yielding a mortality of 2.5 times greater than the basal mortality, which is greater than the sum of the mortalities for isolated injuries. The sum would be 1.3.
Excuse me, Radu.
Here is the injury combination from the ICD-10 perspective. On the left, you have a list of ICD-10 decodes with their mortality as single injury. Mortality, again, is expressed as multiples of the baseline mortality of the cohort. When combined, cerebral edema has a mortality of 17.4 multiples alone, yet combined with focal TBI, SDH,
Radu, can you hear me?
it more than doubles. Please note the isolated mortalities for focal TBI, SDH, and SAH are relatively low, 3.5, 5.1, and 2.4 respectively. A subdural hematoma has a 5.1 multiples of baseline mortality alone. Yet with underlying focal TBI or with an SAH, it almost triples. An SDH with a pneumothorax, it almost doubled the subdural's mortality and 5 times the mortality for the pneumothorax alone. A liver laceration.
It's very interesting, but we really have a lot more presentations. and we're going to have to cut it short. That's a very busy folks. Okay, our next presenter is going to be Mackenzie Leonard. Mackenzie comes to us from SUNY Maritime. She's finishing up there. She's currently our research intern with the clinical research unit. She does have plans to go to medical school, and I wish her the best. She's going to talk about effect modification of the relationship between time and to operation and mortality by age in pancreatic pseudocyst patients admitted emergently.
So my name is Mackenzie Leonard, and I will be talking today about the effect modification of the relationship between time to operation and mortality by age in pancreatic pseudocyst patients admitted emergently, a study of 9,179 patients. I worked on this study with Dr. Smiley and Dr. Latifi. I have nothing to disclose at this time. Adult and elderly patients emergently admitted with the primary diagnosis of pseudocysts of the pancreas have a risk of morbidity and mortality. The aim of our study was to examine the risk factors that were associated with in-hospital mortality in both adult and elderly patients with pancreatic pseudocysts that were admitted emergently. Adult and elderly patients were taken from the National Inpatient Sample Database, which ranged from 2005 to 2014. Clinical data, mortality, and demographics were analyzed using stratified analyses and multivariable logistic regression model with backward elimination to find factors associated with mortality. There were 9,179 patients included in the study. About 73.4%, or 6,769, were adults under the age of 65. About 26.6%, or 2,410 patients, were elderly patients over the age of 65. Mortality was 0.6% in adults and 2.7% in the elderly. Surgical rate was 47.2% in adults and 41.3% in the elderly. In adults who did not undergo an operation, length of stay was the only risk factor that was found to be significant. In elderly patients who did not undergo an operation, there were no risk factors that were found to be significant. In adults who did have an operation, the significant risk factors were found to be age and time to operation. In elderly patients who had an operation, the significant risk factors were age and modified frailty index score, but time to operation was left in the model, even though it was not significant. So if we look at this chart, we can see that in elderly patients who had a surgery, time to operation was found not to be significant with an insignificant p-value, but the modified frailty index score had such a high p-value, odds ratio of 76.7% for every point on the modified frailty index score, that it's possible that that high risk of mortality made surgery riskier. But if we compare time to operation in days between adult and elderly patients who had a surgery, it's very interesting that time to operation was significant in adults, with each day delayed in operation causing an increase in mortality of about 9%, while in the elderly, it was not significant. So in conclusion, age was found to be the effect modifier between time to operation and mortality in emergently admitted pancreatic pseudocyst patients. Thank you. Any questions?
Very nicely done. Thank you, Mackenzie. We're going to move on. Yeah. So we get a return of Mohammed Zishan. And his project is carotid endarterectomy versus carotid artery stenting for carotid disease in octogenarians, and nationwide analysis of 6-month outcomes.
I will be presenting my project on vascular surgery. I did this project with Dr. Babu and Dr. Laskowski from the vascular surgery division. I have nothing to disclose. Carotid artery disease is one of the common causes of stroke in adult population. And CREST trial, which was published in 2010, randomized the patients with carotid disease into two groups, carotid endarterectomy and stenting, and showed that carotid endarterectomy was associated with improved outcomes. However, the mean age of this patient population was around 67 years old, and because of the recent changes in the patient demographics in the US, more and more older patients are coming to us in the hospital with the carotid disease, and especially the patients above the age of 80, they have multiple risk factors, and we might think that an invasive procedure like endarterectomy may be associated with worse outcomes in these patients. In CREST trial, there were only 100 patients above the age of 80, and they could not comment about the type of surgery for these patient population. So the aim of our study was to evaluate the outcomes of carotid artery stenting versus carotid endarterectomy in octogenarian, which was defined as all the adult patients above the age of 80. We performed a 1-year analysis of the national readmission database, and we included all the octogenarian, which was defined as all the patients above the age of 80 years who underwent either carotid endarterectomy or carotid artery stenting for the carotid stenosis or carotid disease. The outcome measures were in-hospital complications, which were myocardial infarction or stroke, in-hospital mortality or reoperations. In our 1-year analysis, we identified a total of 742 patients which met our inclusion and exclusion criteria. And out of these, only 20% of almost 20% of the patients underwent stenting, while around 80% of the patients underwent open carotid endarterectomy. Moving to the results of our study, this table represents the univariate analysis of our outcomes. As you can see, the patients who underwent open endarterectomy, they had lower rates of stroke. However, there was no difference in myocardial infarction or mortality in these patients compared to the patients who underwent stenting. On comparison of the 6-month outcomes, we found that the patients who underwent carotid endarterectomy, they had lower rates of readmissions and again lower rates of stroke. However, there was no difference between the rates of MI, reoperations, or mortality compared to the patients who underwent stenting. Then we performed a multivariate regression analysis to control for confounding variables such as comorbidities in these patients. And we found that carotid endarterectomy was independently associated with lower odds of stroke in these patients. And again, on the comparison of 6 months outcomes, carotid endarterectomy was associated with lower odds of readmissions and lower odds of stroke within the 6 months after the surgery as well. There was no difference between the two groups regarding the myocardial infarction, mortality, or reoperations. So in the light of our study, we conclude that in octogenarian patients with carotid artery disease compared to the stenting, carotid endarterectomy is associated with lower odds of stroke and readmissions. And carotid endarterectomy may be considered a modality of choice for revascularization of the carotid disease in this high-risk patient population. And I will be happy to take your questions.
Thank you, Mohammed. We're moving on to another virtual presentation from Sonia Her. Is she going to be live or recorded?
It's pre-recorded.
It's recorded,
Yeah.
okay. Our topic is perceptions of parotid gland ablation for prostate cancer among men on active surveillance, a qualitative study.
My name is Sonia Her. I'm a third-year medical student. First, I would like to thank the Department of Surgery and the committee for the honor to present tonight. I will be presenting on the perceptions of partial gland ablation for prostate cancer among men on active surveillance. This is a qualitative study done mainly with the Department of Urology at Weill Cornell Medicine. I have nothing to disclose. Partial gland ablation therapy, or also called the focal therapy, is an emerging treatment modality that targets specific areas of biopsy-proven prostate cancer to minimize treatment-related morbidity by sparing benign areas of the prostate. This treatment came about due to new imaging ability to visualize these specific areas of the prostate. Therefore, PGA is less invasive and comes with fewer side effects, such as urinary and sexual dysfunctions. However, PGA is not as definitive of a treatment compared to radical prostatectomy. Thus, it requires further screening and testing and treatment as they already receive on active surveillance. This qualitative study aims to explore and characterize perceptions and attitudes towards PGA in men with lower risk prostate cancer currently on active surveillance. We use the constant comparative method as described by Glaser and Strauss for thematic analysis, where semi-structured interviews are first inductively coded and analyzed to identify concepts that are ultimately developed into overarching themes. Interviews were conducted past the thematic saturation and concluded at 20 interviews. We have 4 themes that we found in our study. First, the feeling of psychological safety associated with lower risk disease. Second, preference for minimally invasive treatments. Third, central role of physician where many patients trusted and followed their urologist's recommendation in the decision-making process. The first 3 themes are very consistent with prior work done on PGA. Our study highlights the 4th theme, which is the theme of the intensity of treatment matching the severity of disease. As one patient put it, they wanted a treatment that was relative to the risk. Some men expressed interest in PGA if cancer were to progress from the lower risk prostate cancer they have now, versus 45% of men expressed interest at the current moment. PGA really appeals to these men as the middle ground that encompasses the idea of curative treatment and also the preservation of quality of life. In conclusion, additional study must be done to understand the patient's competing goals and values to really match them to the treatments and shared decision-making discussions. Thank you for listening. If you have any questions, please reach me at share@student.nymc.edu. Thank you.
Our next presenter is Egon Kaimoli. He's going to discuss complex abdominal wall reconstruction in neutropenic patients.
You have a poster? Yeah, sure. You do? Oh, no, you have PowerPoint, but you don't have a poster here as well? I have it as well. This is just your PowerPoint over here. That's okay. We'll just use it. Okay, great. And then you can use this. Okay.
Hi, everyone. Good afternoon. This is the poster that was accepted. I'm going to go quickly for the sake of time. This was accepted by the American surgeon. However, the title is called The Abdominal Wall Reconstruction in Neutropenic Patients, a Case Series. It was a project with me and Dr. Latifi and some of my colleagues in the surgery. I have nothing to disclose. So it was a common belief that neutropenia equals wound infection, poor wound healing, or sepsis. And historically, surgery would be delayed until neutropenic patients would have their neutrophil counts improve to at least a 1.5 thousand mmK2. But regardless of the underlying etiology or whether the patient was actually symptomatic, it was just a dictum of a number. Recent publications in various surgeries questioned that notion, especially if patients were asymptomatic. And what our objective was is to look at it in our subset analysis of patients who underwent complex abdominal wall reconstruction with neutropenia within the 48 hours prior to being operated on. Our study design, we looked at our prospective database of 236 patients. Our criteria was adult with large ventral hernia requiring complex abdominal wall reconstruction and absolute neutrophil count of less than 1.5 K of cells per microliter within 48 hours of operation. We got 4 patients. This is the description. Average age was 52. Absolute neutrophil count was 1.15 K, so quite a bit significantly less than 1.5. All patients had cirrhosis. 2 alcohol-induced, 1 cryptogenic, and 1 non-alcoholic steatohepatitis induced. 30-day and 90-day surgical site infection rates were actually 0, and patients did relatively well. So our results were encouraging and challenged the traditional notion that neutropenia alone should prevent elective surgical intervention, in our case, especially complex abdominal wall reconstruction. Further studies will need to be done to confirm our findings. Thank you so much.
Any comments or questions for Egon? Yes?
I'm sorry. They had liver cirrhosis, and some of them had previous transplant. That's why we had tacrolimus. So they initially had liver cirrhosis for various reasons, and then they underwent transplant, a liver transplant, and as a result, they most likely had hernia that required a complex abdominal wall reconstruction. So they were on immunosuppressants.
Chemotherapy and those hematologic disorders would be entirely different body right? Don't think we should have that impression that neutropenia of any etiology is okay to operate.
Fair enough.
Most of these patients need an operation. That's exactly elective patients. Some of the things with large hernias, small hernias, incarcerated. We also like to not operate and stuff. So that's why we did that. We need to get involved with folks who treat from serious accidents. They all did.
Okay, our next topic is going to be recorded. It's Arjun Sial on risk factors of mortality in admitted patients with strangulated inguinal hernia in the national inpatient sample.
There's no audio, it's just a PowerPoint, there's no video for it. Okay, so Eric Feldstein. I'm sorry.
Yeah, so next is Eric Feldstein.
Okay. Wherever they may be.
So Eric is going to talk about acute respiratory distress syndrome, patients with subarachnoid incidents, predictive factors, and impact on
Hello, everybody. I'm Eric Feldstein. Today I'll be discussing this poster Thank you. Yeah. Acute respiratory distress syndrome in patients with subarachnoid hemorrhage, incidence, predictive factors, and impact on mortality. I have nothing to disclose. So non-traumatic subarachnoid hemorrhage is a devastating disease. It affects over 30,000 people every year in the US. And spontaneous subarachnoid hemorrhage arising from a ruptured aneurysm or AVM can have catastrophic consequences. Even in the case of survival, after initial treatment, many systemic complications contribute to mortality. Pulmonary complications are the most common non-neurological cause of death in non-traumatic subarachnoid hemorrhage. And of these, ARDS is the most frequently encountered. ARDS is associated with significant increase in hospital mortality, ICU length of stay. Understanding the risk factors predisposing these patients to ARDS can help identify subsets of patients for whom early intervention may improve outcomes. So we used the National Patient Sample Database from 2008 to 2014 to identify risk factors and outcomes in patients with subarachnoid hemorrhage who subsequently developed ARDS for the purpose of identifying predictors of ARDS not previously discussed in literature. We expanded this to include, from previous literature, the Charlson Comorbidity Index, the occurrence of ischemic stroke, status of aneurysmal clipping, and the NIS subarachnoid hemorrhage severity score, all of which are related to the underlying disease process of subarachnoid hemorrhage. This was a retrospective cohort study conducted using the NIS database. The sample contained about 171,000 patients with non-traumatic subarachnoid hemorrhage. We identified cohort A, N of about 7,000 patients who developed ARDS in the setting of subarachnoid hemorrhage. And to compare, we had our group B, which was about 164,000, the patients with subarachnoid hemorrhage who did not develop ARDS. We determined the incidence of ARDS in patients admitted with subarachnoid hemorrhage and identified the risk factors for developing it. Our primary endpoints were discharge to home, other than routine discharge, and inpatient mortality. So we had two multivariate models that were performed to determine statistically significant predictors of ARDS. The first adjusted for patient level characteristics, such as age, gender, the NIS SSS. We also looked at the Charlson Comorbidity Index, cardiogenic shock, stress ulcer, quite a few different things that we examined. The novel ones were the NIS SSS, Charlson Comorbidity Index, the stroke status, and the interventions that we pursued. So for our results, the incidence of ARDS in patients admitted with non-traumatic subarachnoid hemorrhage was 4.1% in 2008 and decreased to 3.3% in 2014. The independent predictors of ARDS, gender, ischemic stroke, presence of fluid and electrolyte disorders, status of craniotomy, craniectomy, and neurosurgical intervention done for the subarachnoid hemorrhage, such as coiling versus not coiling, clipping versus not clipping. So our novel predictors, the NISSS, which had an odds ratio of 1.45 between ARDS and non-ARDS, and the comorbidity index, odds ratio about 1.1. Patients who developed ARDS were less likely to be discharged home, more likely to be discharged to a rehab facility. However, what we had found was that they had a lower mortality rate than patients without ARDS, which was about 20% versus 17%. So our conclusions. The incidence of ARDS has decreased over the past 6 years when the study was examining this. We determined some statistically significant baseline characteristics and predictive factors associated with those who developed ARDS. We identified patients who had risk of developing ARDS for the purpose of risk stratification, which is useful going on research utilization, prevention, treatment. What's sort of been holding up moving on with the manuscript is the decrease in mortality related to ARDS isn't really a finding that passes the smell test. We suspect that the ICD codes are sort of lobbying an ARDS with acute lung injury, and we're not quite getting the correct value for mortality associated with subarachnoid hemorrhage and ARDS. Thank you.
Thank you very much. Next up is Kenji Okamura. His topic is compensation prediction score valid for contralateral kidney after living donor nephrectomy in the United States.
My name is Kenji, PGY surgery resident here. Thank you for the opportunity for presenting our study. The title is Compensation Prediction Score Valid for Contralateral Kidney After Living Donor Nephrectomy in the United States. Nothing to disclose. It has been well known that the remnant kidney function after living donation and then the compensated after kidney donation. The many factor has been proposed, and then recently the CPS score was proposed to estimate compensation for contralateral kidney after living donation in Japan. This study has been performed for external validate the CPS in the United States. We retrospectively analyzed 78 consecutive living kidney donors at the WMC from January 2015 to December 2019. The definition of favorable compensation, the post-kidney donation, is defined the EGFR at 1 year more than 60% of the previous EGFR. And then compensation prediction score has been calculated like this: the 4 times remnant kidney volume divided by the body weight minus patient age divided by 10. If patient is female, plus 4.5. If no history of hypertension, at the 2.2. Here's a result of the our data. Between the favorable and unfavorable compensation group, the ratio of the female has been higher in the favorable group, and then the pre-operative serum creatinine was higher in the lower in the favorable compensation group. And then the CPS score has been 10.1 in the favorable compensation group, and then unfavorable compensation group is 6.1. This has been significantly lower in the unfavorable compensation group. Here's a correlation between the compensation score and the EGFR. As you can see, there's a positive correlation between the EGFR compensation prediction score. So the diagnostic value of CPS, the median CPS was 9.6, and then CPS was significantly higher in the favorable compensation group. And then CPS showed a strong diagnostic accuracy of predicting favorable compensation. AUC is 0.788. Original study was around 8. And then CPS showed a significantly positive correlation with the post-donation EGFR at 1 year. And then other correlation has been seen the age and then remnant kidney volume body weight ratio. Here the conclusion: this study supported that CPS would also be useful to predict favorable compensation of the contralateral kidney and remnant kidney function in the US population of the kidney donor. So if the CPS is low, the more careful management perioperative and follow-up might be necessary. As you can see, the number has been limited, and then this is a single institution study. So one need to validate our finding we need a larger population. Thank you.
Questions for Kenji? Nicely done. All right, next up is Claudia Cozio. She's going to talk about predictive factors in women admitted for childbirth associated mastitis and breast and nipple infections in the United States, a 10-year perspective.
Good afternoon, everyone. My name is Claudia Cozio. I just finished up my second year of medical school, and today I'll be talking to you about risk factors for childbirth-associated breast infections, and I'll be giving you a highlight of a 10-year perspective in the United States. So I have no disclosures. So mastitis affects many women post-childbirth. Up to 33% of women suffer from it during lactation, and it leads to difficulty with breastfeeding. Up to 11% of lactating women also develop the complication of breast abscess. So previous studies have identified risk factors that are associated with breast infections, but the goal of our study was to assess risk factors that are associated with hospitalization for this infection, and specifically to look at the predictive factors that affect the hospital length of stay. So this is a retrospective cohort study using data from the national inpatient sample. So we identified patients by finding those who had a primary diagnosis of breast infection associated with childbirth and were hospitalized. We collected data of a variety of things. So patient demographics, we looked at their hospital course, their admission, procedures, a variety of things. And we use data stratification and backward linear regression to assess how these risk factors were associated with their hospitalization and length of stay. So 4,614 women were identified. Age was the most significant risk factor for rates of admission. And there were many factors associated for the hospital length of stay. So this table's a little busy, so I'll try to break it down. So like I mentioned, age of hospitalized patients was the greatest risk factor. So the mean age was 26.75, which actually corresponds to the average age of the mother at first birth in the United States. And it's notable that almost 50% of all cases of breast infections were in the cohort of women aged 22 to 30 years. Their mean length of stay was 2.83 days. Another result we have is that the hospital length of stay in patients with a procedure, which was defined as a vaginal delivery, a C-section, or other additional obstetrics procedures, it was 3.53 days compared to 2.39 days in patients who did not undergo a hospital procedure. And in patients who did undergo a hospital procedure, they were much more likely to be diagnosed with a breast abscess compared to mastitis or a nipple infection. And as I mentioned, breast abscess is a potential sequela of these two diagnoses. So, hospital procedure was associated with the breast abscess and more severe course of infection. Prolonged hospitalizations were also more strongly associated with urban versus rural hospitals. That's actually consistent with the current trend in the United States. And then socioeconomic considerations and comorbidities were also associated with development of breast abscess or progression from mastitis or nipple infection to breast abscess, and thus requiring an increased length of hospital stay. And these included an emergency admission compared to an elective admission. It included women belonging to a lower income quartile, women lacking private insurance. So these women either had no insurance or had Medicare. And also the comorbidities that were most strongly related were obesity, hypertension, diabetes, and drug abuse. So just a little bit of discussion. So I mentioned age was one of the highest predictors of the rates of infection. So two potential reasons why women in the 22 to 30 year age cohort, why rates were highest, could be due to poor breastfeeding practices in first-time mothers. A second potential reason that we found could be due to mothers' employment status. So current research does show that women employed outside of the home and those in professional careers do have higher risks of infection. So given these findings, it might be beneficial for primiparous women and women who want to return to the workplace to provide them with additional education and resources for breastfeeding and also guidance in adjusting their lifestyle to the new normal. I mentioned that cesarean section and delivery in a hospital is associated with increased infections and rate of and length of stay. So post-delivery, women in hospitals the mother is separated from the baby. That leads to suboptimal breastfeeding practices. So that can lead to things like blocked ducts, which eventually can progress to infection and breast abscess. And all of those things are related to hospitalization and increased length of hospital stay. So here we recommend that hospital try to enhance contact between mother and baby and support mothers who choose to breastfeed to teach them those skills. And lastly, I did mention that there were predictive comorbidities and socioeconomic considerations. So those are things that hospital and physicians could consider in order to better identify at-risk patients and how to prevent, identify, and treat infections. So just to conclude really quickly, these are novel findings because most of the current literature focuses simply on lactation practices, breastfeeding practices, whereas here we look at the underlying risk factors. So demographics, past medical history, hospital course. So this is a new finding in the field. I'd just like to take a second to thank the committee for allowing me to speak today. I'd like to thank Dr. Castaldi and Dr. Smiley for their mentorship, and thank you all for listening today.
Questions for Claudia? Our next two presentations are recorded. First up is Giselle Gill, who's going to talk about mortality risk factors in femoral hernia, an analysis of 7,723 emergently admitted patients.
Good morning, everyone. My name is Giselle Gill, and I'm a rising M2 here at New York Medical College. And today I'll be discussing my research on the mortality risk factors in femoral hernia, an analysis of 7,723 emergently admitted patients. So authors include myself, as well as Dr. Abba Smiley and Dr. Rifat Latifi. Disclosures, I have nothing to disclose. Background, so femoral hernia generally account for up to 4% of groin hernias, many of which present as emergency admissions with significant morbidity and mortality due to various predictors. As a result, the goal of the study was to evaluate these independent predictors of in-hospital mortality in non-elderly patients 18 to 64 years old and elderly patients 65 years and up, of these who were emergently admitted for femoral hernia. So methods include data collected from the National Inpatient Sample, NIS, on patients who underwent emergency admission in 2005 to 2014. And of course, we use the multivariable logistic regression model in order to identify the association of these predictors with in-hospital mortality. So results, as I mentioned before, we had a total number of 7,723 patients who were emergently admitted for femoral hernia, 1,669 of which were men, 6,054 were women. There were 1,549 non-elderly patients and 6,174 elderly patients. The mean age for men was about 51.93 and 80.31 years old in non-elderly and elderly patients respectively. And for women, 52.20 and 80.32 years old in non-elderly and elderly patients respectively. The mean hospital length of stay was about 3.18 and 3.20 days for non-elderly male and female patients respectively, and 6.19 and 6.33 days for elderly male and female patients respectively. So generally, elderly patients have longer hospital length of stay. So results continued. The mortality rate was about 0.6% and 3.5% for non-elderly and elderly patients, respectively, of which both populations, majority underwent surgery. However, there was no significant increase in mortality. The most common type of hernia complication was obstruction. 88.1% of adult patients and 89.7% of elderly patients had this complication. Overall, the older the age, the earlier the operation, invasive diagnostic procedures, long hospital length of stays, and being male increased the odds of mortality in elderly patients who were emergently admitted for femoral hernia. Whereas it was only being male and long hospital length of stays were the main risk factors for mortality in non-elderly patients who were emergently admitted for femoral hernia. And here I have this table, which basically describes the results I just stated previously. And this was via once again, the multivariable logistic regression analysis method. So in conclusion, early operation increased the odds of mortality in elderly patients with femoral hernia admitted emergently. However, hospital length of stay and BEMER were the principal risk factors in hospital mortality for all patients. And these are my references. So thank you so much for listening. If you have any questions, please feel free to reach out to me at the email below, and have a great day.
Our next virtual speaker is Laura Museau. Her topic is Center Petitioning of the United States Department of State increases access to living kidney donation for legal immigrants and naturalized citizens on the transplant waiting list.
Good morning. My name is Laura Museau, and I'm a fourth-year medical student at New York Medical College. Today, I'll be presenting the abstract entitled Center Petitioning of the United States Department of State increases access to living kidney donation for legal immigrants and naturalized citizens on the transplant waiting list. According to UNOS, there are about 101,000 patients who are currently waiting for transplants. However, in 2019, only about 23,400 of those candidates received the transplants, whereas 4,100 of them died waiting. These statistics have been the driving force behind initiatives aimed at increasing access to living donors, thus expanding the donor pool. Furthermore, live donor transplantation affords shorter wait time and better outcomes when compared to deceased donor transplantation. Problems arise, however, when considering legal immigrants or naturalized citizens in the United States, because their living-related donor candidates may exist in their country of origin, but they're not able to be considered because of immigration restrictions. Therefore, we aim to determine if petitioning the Department of State on behalf of foreign national living donor candidates will help increase access to live donor transplants for legal immigrants and naturalized citizens. This was a single center retrospective study. The Transplant Center sent 24 letters on behalf of 24 live donor candidates who were pre-screened based on blood type, renal function, and sonography. And these 24 candidates ranged from countries of Jamaica, Dominican Republic, Haiti, Ghana, Barbados, and Nigeria. The recipient outcomes of these foreign nationals were then compared to the recipient outcomes of the 25 US resident donors from this transplant center. Of the 24 letters that were sent to the Department of State, they approved 21. Of the 21 that were approved, 7 were denied because upon further screening, 4 candidates had hypertension, 1 had diabetes, 1 was a positive cross-match, and 1 withdrew. Of the 14 that became donors, this is the data. The UNOS clinical compliance was about 10% greater for foreign nationals than resident donors. Similarly, the UNOS laboratory compliance was about 15% greater for foreign nationals than resident donors. The recipient wait times was shorter for resident donors as to be expected, but still similar. The recipient graft and patient survival at 1 year was about the same between foreign nationals and resident donors. At around 3 years, the foreign nationals graft and patient survival was 86% and resident donors was 96%. Therefore, Center-specific petitioning of the Department of State can provide access to live donor transplants for legal immigrants and naturalized citizens within the United States. Foreign national donors were compliant with data reporting requirements, and recipient outcomes were similar to that of US resident donors. For this reason, this is a viable mechanism to improve access for underrepresented groups requiring transplantation. Thank you.
All right, our penultimate presenter is Christina Eng. Her topic is, does rupture of the alar ligament predict conservative treatment failure of atlantomaxial rotary subluxation?
Hi, everyone. My name is Christina Eng. I'm a third-year medical student, and I worked with Dr. Kynan to explore the question of, does alar ligament injury predict conservative treatment failure of atlantoaxial rotatory subluxation? I have nothing to disclose. So for some background, AARS is a rare injury in adults. It's consistent with rotatory subluxation of the C1 vertebrae on C2. And the treatment really varies. It can range from closed reduction with immobilization to surgical fusion or fixation, or a combination of both of these things. So we know that injury to ligaments may heal poorly in adults, and this can be evaluated with MRI. And if there is ligamentous injury, this often requires surgical stabilization. In particular, we know that the alar ligament is important in restraining the rotational movement at the atlantoaxial joint. However, we don't know the prognostic importance of the alar ligament when it comes to successive non-operative management of AARS. This is the Fielding and Hawkins classifications of AARS, of which there are 4 types. Type 1 being displacement without anterior shift and an intact transverse ligament. Type 2 being anterior displacement with 3 to 5 millimeters of shift and transverse ligament injury. Type 3 being anterior displacement of greater than 5 millimeters, and type 4 being total posterior displacement. These 2 figures just highlight important ligaments. You can see here, this is C2 and this is C1. In particular, I wanted to highlight this is the transverse ligament, and there are 2 alar ligaments on each side. 2 in total, 1 on each side. So we did a case report and also a literature review for this project. For our patient, we had a 28-year-old female who presented after a motor vehicle accident with severe radiating neck pain, hand paresthesia, and her head held in a cock robin position. So for her, her head was tilted to the right, and she was neurologically intact. For imaging, the cervical spine CT demonstrated type 1 AARS, and the cervical spine MRI demonstrated ligamentous injury in the apical and right alar ligaments, as well as the tectorial membrane. Initially, the patient was treated non-surgically, and a partial closed reduction was achieved. This is her cervical spine CT, where you can see the rotation of the C1 on C2. This is her MRI, and you can see this bright spot here. It's the increased T2 signal in the right alar ligamentous complex. Unfortunately, our patient returned 2 days after her discharge with worsening neck pain and headache and dizziness. So ultimately, her treatment was an open reduction of the AARS and posterior instrumented fusion of C1 to C2. Her outcome after surgery was significant relief of neck pain and other symptoms, and her cervical alignment and instrumentation remained stable at 3 weeks and 6 months follow-up. This is the lateral X-ray showing her posterior fixation. So for our results of our lit review, we found 19 adult patients with traumatic ARS who underwent MRI evaluation for ligamentous injury. Including our patient, ligamentous injury was found in 6 of these patients, with a large majority, about 83%, undergoing surgical treatment. 3 patients in total had evidence of alar ligament injury specifically, 2 of which failed initial conservative management. 1 had successful initial reduction, but due to an additional transverse ligament injury, all 3 patients ended up requiring surgery. So conclusions of this study, there is no general consensus for the management of adult traumatic ARS patients with unilateral alar ligament injury. Our case and review of the literature suggests that unilateral alar ligament injury is a prognostic indicator for failure of conservative management. And we concluded that the managing spine surgeon should have a low threshold to recommend surgery for these patients. Thank you all for listening.
Any questions for Christina?
You're welcome.
All right, before I introduce our last speaker, I just want to ask everybody to stick around for a few minutes because we're going to judge and award the prizes for the presentation. So our last presenter is Aparna Vencheswaran. Her topic is improved efficacy of complex medical decision-making in trauma ICU patients with involvement of palliative care team.
Do I just hold it? Well, good afternoon, everybody. My name is Aparna Vencheswaran. I'm presenting on behalf of my group on our project, which is now covered. On our project, which is improved efficacy of complex medical decision-making in trauma ICU patients with involvement of a palliative care team. Okay. This better? Better? Okay. Sorry. All right. Okay, we have nothing to disclose. So a little bit of background on our project. So we noticed that a greater number of older patients, specifically over the age of 65, were manifesting with premorbid conditions, were surviving what were previously catastrophic traumatic injuries. However, they were left debilitated with diminished quality of life. Palliative care as a field is uniquely suited to address the goals of care in this specific patient population. However, the data shows that surgical patients, as compared to their medical counterparts, do not often receive palliative care or palliative medicine consults. And these consults are often reserved for the sickest members of the patient cohort. So we wanted to kind of elucidate why there are these common misconceptions about palliative care and make a case for why palliative care integration earlier on would be wonderful for our patients. So our hypothesis that we sought to prove was that earlier inclusion of palliative care in the trauma ICU could lead to decreased ICU length of stay, decreased hospital length of stay, and decreased hospital complications. We sought to prove this hypothesis using a retrospective chart review that evaluated the impact of palliative care consultation on patient outcomes for the first 3 years after the palliative care service was introduced at Westchester Medical Center. As I said earlier, for our methodology, it was a retrospective cohort study. Our palliative care intervention group was derived from the trauma registry, and the patients that met inclusion criteria were those that received palliative care consultation in our study period. We also put together a cohort of non-palliative care patients who did not receive a palliative care consult that were taken from the trauma registry during that study period as well from the remaining group. And we, in order to eliminate confounding, we matched our cohorts by age, sex, race, GCS score, and injury severity score. These were our statistical analyses. Of note, any p-value less than 0.05 was considered statistically significant, and the top 5% highest values of our continuous outcome variables were eliminated to diminish the effect of outliers. In terms of our results, palliative care patients were found statistically more likely to have a DNR code status. They were statistically less likely to have a tracheostomy tube placed, a PEG tube placed, experience a complication, or be readmitted to the ICU. While palliative care patients showed a higher mortality rate, we found that both the palliative care patients that survived to discharge and those that passed away during the study period showed a statistically significant shorter length of hospital stay, ICU stay, and time on the ventilator. In terms of significance of our results, we found that they did in fact support our initial hypothesis that the integration of palliative care could positively affect patient goals or patient goals of care, excuse me. And this was shown through our primary outcome measures reflecting in accordance with our hypothesis. We think that one of the strengths of our study is that because of the case control matching, we can attribute our conclusions more so to the palliative care intervention than any of the other factors listed. In terms of some limitations of our study, this was a one-center study with a relatively small N. We'd like to expand upon that for greater statistical power in the future. We weren't able to get significant results for measures of symptom burden experienced in our palliative care group. Examples of that would be whether patients experience depression, anxiety, trouble sleeping. So that would be really interesting to study for future projects. And finally, the palliative care consults were requested on average 16 days after the patients came into the hospital. This is significantly later than what the recommendations in the literature are of 72 hours in some studies. So we believe that potentially if palliative care had been integrated earlier on average, we may have a greater effect on our outcome measures. These are our references. Thank you so much for your time.
Any questions? Thank you so much. All right, I'd like to ask our panel of judges to convene and deliberate.
All right, the moment you've all been waiting for. So it's our tradition here at this scientific meeting to award cash awards for the best presentations. These awards are in the honor of Anna Samartzis, who was a resident here at Westchester, who unfortunately coming to work one morning was hit in her car and died in a car crash. So this is in her memory and her honor. So we have 3 classes of awards. There's an award for basic science. There are awards for the podium presentations and awards for the poster presentations. So the Basic Science Award goes to Lior Levy for regeneration of bone and non-union defects in rat femurs using multipotent adult stem cells. Actually, if I could just ask everybody to hold their applause until the end, and then we can, there wasn't much competition. There was only one basic science paper, so that was sort of easy. So the winners for the podium presentations, Dr. Inkyu Lee for solid organ transplantation using hepatitis C virus positive donor organs. Dr. Matthew McGurk for reoperative surgery following CAWR, should we look past 30 days? And Shakira Call for the Cancer Institute, A Place of Anxiety. And the poster presentations, the awards are for Mohammed Zishan, carotid endarterectomy versus carotid artery stenting in octogenarians. Kenji Okamura for is compensation prediction score valid for contralateral kidney after living donor nephrectomy. And Claudia Cozio for predictive risk factors in women admitted for childbirth associated mastitis. So congratulations to all the winners.